Thanks for doing that.
I am filling in for Sarah, who unfortunately could not be here today. I will go ahead and start. Good morning, everyone. Welcome to the November meeting of the Mental Health San Francisco Implementation Working Group. I now call the meeting to order. Please note that this meeting is being recorded on WebEx. The recording will be available on the Mental Health SF website. I will start with the land acknowledgement. The San Francisco Department of Public Health staff acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Roll call. Ben.
So I am playing Diana and myself today, so hat off. I'm now Diana. So I'm going to call roll call. Please say here or present as I go through. Member Fields?
Present.
Member Gonzalez? And she's coming, she's on her way. Member Hammer?
Here.
Member Lipton?
Here.
Member McGuigan?
Here.
Member Patterson?
Present.
Member Salinas?
Present.
Member Short is absent. Member Wong?
Present.
All right. Let's see, we have 7 out of 9 members present. We have quorum. And so we're going to continue. And we're going to vote to excuse absent members. Can we do that? We know that Annie's here. Can we go ahead and do that without her here?
Yeah,
Yes. Okay. Per the bylaws, the IWG must vote on to excuse an absent member. If the working group does not take such vote at a meeting or at a previous meeting, then the minutes shall note that the absence is unexcused. Any member who misses 3 regular meetings within 12 months without the express approval of the IWG at or before each missed meeting will be deemed to have resigned from the IWG 10 days after the 3rd unapproved absence. So that's what's up. Let's see, we do have an excuse for Sarah Short, who is on the East Coast and is sick. And so interim chair, Salinas, are you in any discussion or should we move it to a vote?
I think we can just move it to a vote.
Okay. So I will now call roll call on each member to vote yes or no to excuse member Short. So vote yes to excuse, no to not excuse. Member Fields.
Yes.
Member Gonzalez. Oh yeah, she's out. Member Hammer.
Yeah.
Member Lipton.
Yes.
Member McGuigan.
Yes.
Member Patterson.
See.
Member Salinas.
Yes.
Okay, member Short is the absent one and member Wong. Yes. Okay, thank you. We have 7 yeses and the majority vote to excuse the absence. Thank you. Back to.
So today we have the following goals for our meeting. We will receive an update on behavioral health services and mental health SF from Margot, who is here. Perfect. Receive an update on the Street Crisis Response Team program. Review the draft IWG progress report. Receive an update on IWG membership and governance, and plan for the upcoming IWG meeting agenda. We will have the following presenters today. Marlo Simmons, the Deputy Director of Behavioral Health Services Division at San Francisco Department of Public Health, who will be providing an update on behalf of Dr. Hillary Kunins, Director of Behavioral Health Services, Dr. David Kading.
Oh, that's
Okay, it's all like,
yeah, it's all jumbled. That's an old one.
Oh,
Yeah,
I see.
sorry.
I'm supposed to be
But
reading
then
that.
read the second one.
Okay, April Sloan,
Yep.
Section Chief of Community Paramedics Operations with the SF Fire Department, who will share an update on the Street Crisis Response Team since its reorganization. Great. Are we going to we're going to delay the approval of meeting minutes because Marlo is here. And so we will go ahead and hear from Marlo. I am kind of improvising here. Is that what we're doing?
Right.
That's wonderful. Thank you so much for being here.
Very happy to be here. Nice to see so many familiar faces, and it's been a minute. Been a lot of time with you all early days, and since Hillary's been here, I've been working on lots of other fun stuff across BHS. I guess that's just by way of introduction. I'm Marla Simmons, Deputy Director for Behavioral Health. And I'm going to talk a little bit about first, there's really nothing much to report on the Board of Supervisors. We don't have any hearings scheduled, nothing calendared at this moment. Talk a little bit about different updates that are happening across the domains with our implementation of mental health SF, and touch on the street team's audit. Hopefully I can answer questions if people have them, engage in any conversation we have time for, and then phone a friend with Valerie. If there are questions I can't answer, and then of course we'll obviously just note them and come back if I answer the question. So a lot continues to happen with the Office of Coordinated Care. We are up to about 514 new referrals every month. Some of those are coming through the triage and transition team. Others are coming through the Behavioral Health Center and the Behavioral Health Access line. We have a lot of data that we are capturing in Epic that shows the work that's happening around the best neighborhoods, the best care team, and shelter behavioral health. As we move our entire system into Epic, we expect to have more engagement data. So this is a lot of the OCC data, but not necessarily every single thing that's happening. And that will get a clear picture when Epic comes on. Next slide. So, and as we've built out the Office of Coordinated Care, really focused on engagement and follow-up after referrals. This is one example of some OCC data that we're tracking for 206 clients that were referred by the fire department. You'll see the data here that 177 were actively followed up by the OCC. There were 25 that were also referred to the Department of Homelessness and Supportive Housing, HSH, and then for reasons that I'm not completely clear, I did not have follow-up. As far as the outcomes from those 177, 29% were connected to folks that were existing providers. There were 15% were connected to new providers, and then 49% were provided care coordination services, which is pretty robust, meaning there was active outreach, possibly engaging with a hospital at discharge, coordinating with other providers who are not necessarily in the behavioral health system. So this is actually, very active part of the process. And then 7%, there just wasn't enough information for us to follow up with them. Next slide.
Marlo, do you
Yeah.
want to pause after each one, or would you rather make it through the deck?
No,
and-
however it works best for the group, I'm happy to, I will pause.
So are there questions about and you can bring them up later, but just because we have the numbers and stuff, is there anything? And Steve, I'm going to make sure that I ask you first, as the remote person, is there anything that you had about OCC before we move on?
Not yet.
Okay.
But thank you for doing that. I've never
Yeah.
been referred to as a remote person before, but I might like that in this day and age. Thank you.
James?
Just on the 49%, the 87 were provided care coordination services.
Yep.
What does that entail, and what's being monitored on that?
Yeah, and so the specific data outcomes, I'd have to follow up. My understanding of the care coordination is it's pretty active. It is reaching out to the client, really assessing what their needs are, kind of how they've engaged in the system, what's happening. In many cases, it's support with planning around discharge, like if someone's in the hospital, it may be coordinating with different providers in the system who are not behavioral health providers. So it's a whole wide range of activities that are happening. And then of they may not necessarily have been connected yet to a service. This is point in time. And so these folks may still be actively, we're reaching
So
out to
those are
them.
still being monitored to see.
And I can add, otherwise, Brett, that runs the OCC is coming for the SCRT presentation as
Gotcha.
well. So if
Okay.
we can grab a couple minutes with her, she can probably provide more.
Well, would you rather that we hold OCC questions rather than?
If that makes sense.
I think it depends how much time.
Yeah.
we have around.
You have 2 more slides, so.
I have one question about the referrals. In the, so the 170, the 206 cases were referred by the fire department. I think their slides presenting later say that they're doing about 1,200 visits a month, encounters per month, if I read that correctly. So this is about 16%, 17%. I realize that encounters could mean the same person could be encountered more than once, but so I assume that here we're talking about 206 unduplicated clients. I mean, basically, it's just, so it's something that's north of 17%.
Yeah.
Is that, I'm trying to figure how to evaluate that just in terms of the numbers.
Right. And I would definitely encourage talking more to the SCRT folks. But my understanding is that you arrive on the scene. Some folks get resolved in that moment. Some folks you can't find them. Some folks you actually engage in them and maybe they have other needs that are not behavioral health. So I'd say that is the portion that they're identifying as needing extra support from behavioral health.
I suppose I should ask, what does resolved means in this context?
Yeah, and that's a good question.
I mean, you could have an immediate crisis that is resolved, or at least appears to be resolved. But it doesn't necessarily mean that someone should not have follow-up. And I guess that's the question is, are we referring an adequate number or an appropriate number for follow-up?
I think those are good questions.
Yeah, absolutely.
Yeah.
I've recorded them. We can come back to them with the next presentation.
Yeah, no, well, I was asking it from the department.
Oh, from this, yeah.
There are 2 perspectives here. There is, from the fire department standpoint, particularly the skirt teams.
Yeah.
Are they getting people into OCC or other appropriate placement? And the second question is from this department standpoint, is the department capturing people who are,
I think
what
Simon.
do I say, candidates?
I think Simon Pang's supposed to be coming today, and he's gonna. It's
Yeah,
April.
it's April. Simon had a family emergency.
Oh, okay.
But I hear that Heather Weisbrod is also going to be here. And so
Okay.
she'll be able to talk about.
They'll
that
be able to
here
answer
on
those questions.
Yeah,
Or give you clarification. Maybe not answer them.
yeah. But we'll have both sides there to talk about it.
It's a good questions.
Are there other questions about the OCC?
I can go home now. I asked.
Actually, this is Member Fields. I now that you've given me this much time, I do have one question, about the follow.
Remote people get one shot only.
Yeah.
Yeah, right. Yeah, for 2.5 years. So my question is about the connection that continues with OCC after a referral is made. In a couple of specific instances, because there's often a difficulty later down the road with the Department of Homelessness and Supportive Housing being able to respond to immediate needs. Does the OCC continue the conversation with that individual when they're referred, and even to an existing in-system provider, to make sure that there's a continuity of intent with the existing providers when a referral is made? Is there some way you could discuss, because one of the things about the OCC model that I think was particularly critical is that it isn't a pass the baton model, it's a stay involved model, particularly with individuals who might be seen at by the skirt team or by a street intervention where clearly they're presenting a lack of supportive services for their needs. So what happens after the referral gets made to the existing provider or to another department? Is that case dropped, or is there a methodology for continuing a dialogue with those entities that receive the client when they do express an interest in follow-up services?
I can touch briefly just on the vision, but I'm really going to let Heather answer questions because so much of what you're describing is based on capacity. The vision is that we are engaging with folks and holding on to them until they are securely connected somewhere, and not just, here's a sheet of paper, have a nice day. And that there are certainly the intent for folks that are having kind of ongoing challenges to check back. Did they connect? Are they still good? What's happening? But I really am going to defer to Heather to answer.
Yeah, and I'm coming over for the mic, not to be creepy. I just messaged Heather that she didn't expect some questions when she joins. I will also add that part of the point of the transition to Epic is to allow us greater visibility to track people, to allow the OCC to get closer to reaching that vision because they can actually follow people better in the system. So.
I mean, I could kind of answer that question, actually. I mean, yeah, I think that OCC is following people. I've had a couple people on our team. I mean, and they have access to Avatar, so they can readily, email us and,
Avatar is just.
an Avatar, for some of the folks that don't know, is the current EHS electronic record system. And we do get emails. I mean, sometimes it could be, some folks, we find out not expediently, and some folks we do find out expediently. And I think it's for those folks that we're seeing on an ongoing basis. I mean, they easily see that we've been working with them, and so we just get alerted that they've seen them on the street. We have some high-profile clients that we're outreaching all the time, and until they can actually get a hospitalization and stabilized, we can't. There's not much that we can do, and we've been able to work successfully with SCIRT to finally get folks, maybe with the upteenth time they get 5150'd, and these are long processes, right? Like we actually end up, the number of times that SCIRT is having contacts with people helps us build cases for conservatorship, really. That the number of times SCIRT is constantly seeing them on the street, they get transported to the ED, they end up back on the street, and you're doing this revolving door is basically we're building up a case with the fire department, with all those fire department visits for someone to get conserved. And finally, then we've been able to work together with SCIRT and OCC to then plan for an admit, because once someone is then, we've filed a TCON, once they can, a temporary conservatorship, then we've worked with SCIRT to then be like, okay, now next time you 51, now everything's in place so that the next time you 5150 them, they're actually going to get held, and they won't just end up 2 hours later and you'll see them again on the street, right? So, I mean, we are working that way with SCIRT. And then there are folks who are not engaging in care. We've recently had someone like that who was just refusing our services. And then we worked with OCC. They got picked up by OCC, and then they're going to give it a try with Felton, So, I mean, those things are happening, right? That OCC will start following someone, we'll have case conferences, and then we'll kind of brainstorm, well, what can we try since this person is repeatedly refusing services and at PS every single week, right? So, I mean, that is happening.
I think another aspect to that question is, and I think maybe it'd be interesting for us to spend a little more time on the people who are actually, through the miracle of a really effective intervention, agree to go into services. I understand we have a constant revolving door, but there are people who come through, say, door urgent care, who get into an acute diversion program. They get in there, and then the next step for them becomes the most difficult in terms of resources that they may want. And it would be very few of the people in our acute diversion programs have an active case manager. And it's certainly a part of the revolving door that they may be reaching a level of stabilization, and maybe the next step is the most important one, but they end up going into a shelter or back to their hotel room in the Tenderloin, and then we see them back. So my vision, Marlo, which you referred to, or about this whole thing, was that there would be a collaborative discussion between the individual receiving services, the program that's currently working with them toward a goal of stabilization and being able to remain in the community, and this ongoing Office of Continuing Care, so that the discussion is about the next level of care. And we can't keep doing it the way we are, which is this linear process whereby a lot of individuals are ready to go on in treatment, but there isn't a bed available at the moment, or they still need some support to make that decision, but they leave 24-hour care and drop into the community with inadequate support. And then they end up back in the emergency room. So, I mean, that's the vision about this plan that I'm excited about, is people who engage in treatment have a collaborative advocacy going on for them to continue in services and get services that are appropriate, or remain in a service long enough for a resource to open up. And I'm hoping that's part of the eventual goal of the OCC methodology in the county.
I appreciate all the comments people are making, and I do think that OCC is evolving all the time. And so it may be great for Heather to come in at some point and kind of update on how workflows are happening and what data is being collected. So I appreciate the vision, Steve.
Other comments about OCC? Let's move on.
All right, next slide.
Oh, and this is where it is like she's having trouble with her connection.
Okay. Should I just go off
I
paper?
think go off paper, and as soon as she can get her system back up, she will advance the slide.
All right, and I now cannot remember 14. So we are at New Beds Mental Health Service Center. And I understand that a lot of these things this group has been discussing for some time, but the bed optimization study, which is the update of an older study that was done, there are preliminary results that are being reviewed right now. And so hopefully this group will be getting a little more detail soon. On the crisis stabilization unit, we are anticipating being able to break ground shortly. Summarize, we are working on an evaluation, and there will be a presentation to this group next month and kind of going into the details of that evaluation. And as you also know, we've been working on expanding dual diagnosis beds, which include 30 beds for women with children. Sometime in the first few months of 2024 is the target. And then we also recently got approval from the Health Commission to expand a couple beds at Cronin House and a handful, 3 beds at Centerpoint, which are out of county facilities, will serve kind of as an overflow as needed. And then the long-awaited Mental Health Service Center, we are at 1019 Market. And I think this also is not new, is we're still in kind of city real estate negotiation world. And so all of these things will remain on the radar and be updated as we have new information. Any questions on that?
Where is the dual diagnosis program for women located? What neighborhood?
There are, and I just looked this up, there are 2. One, I think we do not know. It's like a half and half. It's not all in one facility. And Valerie, I'm gonna
test it.
Okay. I just was looking at the last MHSF planning slides, and it looked like there was 18. Let's wait for David to respond. But it's not all one facility, is the way I understand it. But there's 2 different programs that are going to have this help us reach this capacity.
Okay, and then case managers will be able to refer via RSOC, which is the Residence, whatever, of care. Is that how that'll be accessed through the way that all the other dual diagnosis beds are?
I don't know otherwise, but that is my understanding.
Question. What, on the crisis stabilization unit, what's your anticipation as to the duration of the renovations? And when opening might be?
Do we have an ambitious?
24, 25.
I think it's supposed to be early.
These things.
It's kind of, it's kind of a long wait, and I realize it's been hard to find the right space, but I know an awful lot of,
estate and
I know an
space.
awful lot of CSUs that get done very, very quickly around the state. And, and this seems to be taking longer than it probably should, just given the need for this type of service and the support it can bring to the script teams and to other, and actually the hospitals in San Francisco.
I don't think anyone would disagree.
Yeah. And hopefully in the lifetime of the IWG, we'll see a mental health service center.
Could I ask two
Please.
quick questions? On the CSU, is the intention to run it through county, or is it going to go out to possible contract through RFP?
I think we're gonna.
That's the
We're gonna
services part, not
RFP it.
just the building, yeah.
Yes.
You're going to RFP it?
Yeah,
Okay.
that's the
Good.
current plan.
Yeah, right. And second question, before we were all up and rolling, there was a sizable increase in board and care beds at a particular provider in San Francisco, a for-profit entity. I'm wondering if we've never seen any data on that. Who's gone in? How are they stabilized? Are people leaving the facility? I'd like to request an update on the cost of those beds and the success numbers in terms of people being able to remain in that environment.
And Steve, specific to ANA or board
Yeah.
of care expansions in
No,
general?
specifically to ANA, because that's in the county, right? That's a San Francisco based. And the more we can have in county
We have
places.
ANA. And
Hmm?
ANA has in county and out of county beds.
Yeah,
But
yeah,
a
but
lot of the expansion was in county.
are we using both kinds when we're referring people out of county and in county based on what availability, or are we focusing on in county? Do you know?
We always prioritize keeping people as close to home as possible, but there may be a specific need that better aligns with like a strength of a particular program.
Okay, great.
I'm doing my creepy thing again. Steve, I will just note, we don't have anything scheduled. I don't know whether it'll move forward. I do know that there's been some interest at the board in a hearing at some point on residential care facilities, and specifically some of that inquiry is related to board and care beds. So I think that aligns with your interest. We do intend to take a closer look at it, at what data we have. Yeah.
Thank you. Thanks for that.
Other questions? All right, moving on to slide 15 for analytics and evaluation. Very, very exciting to announce that we have added 2 new analysts to that team. Getting that team fully staffed has been a high priority for some time. That has kind of slowed down achieving some of our goals. Now our next deliverable for that team is the public dashboard on ICM and residential substance use wait times. We're working with the DPH communications team on getting that up and live. Any questions on A and B? So I think that was all of the slides that I had. The last thing that we wanted to mention is the street teams audit. Great timing that SCRT is coming today to talk with you all. Hopefully you all have received a copy or know of that audit. It was done by the Budget and Legislative Analyst Office, looking at the 11 different street teams that happen in San Francisco. Lots of really interesting data on cost and utilization and purpose and how folks are working together. The report included recommendations for DPH, homelessness and supportive housing, as well as the fire department. There was kind of a range of responses from DPH about the recommendations. Some of them were, kind of the recommendations were, the report obviously was based on, I think it was 21, 22 data. And so a lot has happened in the last year. So a couple of the recommendations weren't really relevant because of how like SCRT has been reconfigured. We've also improved a lot of our monitoring and data reporting. So some of that recommendations related to that weren't as relevant. So in the report includes our responses to all of the recommendations. And then just kind of overall performance and connection and follow-up. A lot of that stuff has been improving over the last year. So the report maybe wasn't based on the data that's most current. And our responses are based on the most current data. So I will pause there and see if there are any questions about that.
I do have one question. I mean, it's good to know that the data collection and reporting has improved. And again, we've asked for the data and we still haven't been getting data. So, I mean, since it's there, it seems like it could easily be forwarded to the IWG, since this is a program that was created by the mental health staff. And I don't know if there's, again, any intention to do that.
And are you talking street crisis specifically or some of the other 11 teams?
The street crisis, because we can very clearly request, because that is a mental health staff program. That's the only one we actually have any purview of. I mean, sure, we could get all the data, but I don't know that.
So I think since they reconfigured and really brought SCRT under the fire department, I think it's, and to the extent that there have been conversations about getting fire department data, I have not been involved in that, but there definitely data that they can provide that we want to request from them. And then a lot of the data that BHS has is really about like the follow-up data and things where we're still engaged with SCRT, but since the fire department is really, and
I can speak to it too.
Okay.
Sorry, I decided to stop being creepy. So.
Popping up in different places.
I know. Keep you on your toes.
They put.
So I always think I'm not important to this, but so I do want to clarify. I think there used to be a mailing list for this dashboard, and there isn't anymore. It is still posted online whenever it's ready, and so they are still making them public. They're not like not making the data. I don't think there's a mailing list anymore. What I understand about the process, and we can confirm with April Sloan and with Heather, is that DPH is still contributing follow-up data to that dashboard from the OCC, and then publication of the dashboard is moved to Department of Emergency Management now, and so it's up to their analysts, like the timing and the pace at which that's released. I know it's a few months behind, I checked, but it is being posted publicly. What we can ask about is whether they are intending to restart a mailing list or develop a mailing list associated with it that I think would make it easier to.
And if they have a landing page for that, we can include that on the resource list of IWG.
Yeah, it's the SART page. Yeah, just their regular.
Okay.
website. So they still are publishing it. Just I think there is a bit of a lag from when it was reconfigured. Certainly talk to to Sloan about it in more depth of where they are catching up with that, but they are still publishing data. We are still contributing regarding our follow-up, but it's no longer under our direct purview to control the release of it, so.
Yeah.
So, yeah, September is the last,
Okay.
yeah, so.
And we can put this, for IWG members and any members of the public who are here, we have a resources area of the IWG website that has reports and different things like that. We will put this website under that resource so that you have it earmarked and can come back to it on a regular basis.
I forgot I had more. We received some answers from Dr. Pading. So the dual diagnosis program for justice involved women and children will be, if permitting is successful, will be in Soma on 10 Hallam Street, so near here. And as I said, the target date for opening the crisis stabilization unit is end of 2024.
And so I misspoke. So it is, the 30 beds are together in one facility.
According to.
Perfect. So there's a lot happening.
Yeah.
And then that could change.
Good. This is our world.
And so it's specifically justice involved with it then?
Yes.
Okay.
Any last questions?
Yeah,
I
thank
imagine
you.
we're coming up against my time.
Steve, go ahead.
Just one last question for me on this one. The Women with Children program, when it says 30 beds, is that 30 beds for the mothers and additional space for the children, or is it a total of 30 beds? And I just want to, I don't know if the other people that IWG realize this, but Progress Foundation has been providing Ashbury House, which is an existing residential treatment program funded by Medi-Cal through the health department, mainly for women with children since 1995. It's a 10 client, 10 children model that slips. Obviously, some moms have 3 kids, some moms have none, but it's been there running and operating for close to 20 years.
Did you hear these questions? Curious if it's 30 moms with 30 babies or the babies are part of the 30?
In how we've talked about similar programs, I think like Epiphany and stuff like that, it's typically the benefits, the treatment, it's the treatment. It's not.
I'm not sure if you heard that the 30 is the treatment beds. So those would be for the moms. So we would need to find out more details about what the baby capacity is.
And
Or,
is
or
it
child capacity.
okay? Child. I was wondering if there's an upper age limit of the children.
There usually is, yeah.
Yeah. Okay. Thank you. But no lower age.
There sometimes there is, it depends on the contract.
Yeah. Yeah, with Ashbury, we have babies, newborns with their mom. So, but there is an upper age of 12. Okay, thank you.
Any last comments,
I'm
questions?
tracking all the questions we have.
Perfect, thank you.
That's it?
That is the end of my presentation.
Okay. Any questions from the IWG before we move to public comments? Mr. Steve, comment? Remote Steve? You're good? Okay, I
Fine.
see you good? Are we ready to move to
Yeah.
public comment? Okay. All right. So, members of the public who wish to provide public comment on this agenda item, which is the Mental Health San Francisco Department update, you are invited to participate in 3 ways.
Thank you.
First, I'm going to call on those who are in person. There's no one here. Then I'm going to call on participants who are joining online. If you are participating online and would like to comment, please raise your hand and Kaylee will call in and unmute you. And then I will call on those joining by phone. If you are participating by phone and would like to comment, please press pound and then pound again, then dial #3 to line up to speak, and a system prompt will indicate that you've raised your hand. When that happens, the system indicates that you have been unmuted and you may begin your comments. So Kaylee, are you seeing anyone that's from the public who is lining up to speak virtually? online or by phone?
I do not see any hands.
Okay, we'll give it just a minute to make sure that people can push the. Okay. Public comments now closed. Let's go back up to the minutes, please. That is slide 7, Taylor. Thank you,
Great to
Marlo.
see everyone. Thank you again
Thank
for
you.
your ongoing commitment and advocacy on behalf of our.
Thank you.
All right. So, Chair.
We will now move to discussion item 1, approval of the October 2023 IWG meeting minutes. These minutes are posted on the IWG website. Are there any changes to the minutes as posted on the IWG website?
Are we no longer getting the, I don't remember seeing this. Did I just miss it?
Your next speakers.
Yeah. Who sent it? No.
Haley did.
Haley.
Haley did. It might have been Diana. Diana's on vacation.
Okay.
Yeah, that might have been it.
Maybe it was the photos. Okay.
I didn't print them.
Are there any changes to the minutes? Yes.
Valerie,
Yeah,
you missed the last meeting.
I was in surgery.
So I understand that. I'm glad that you're back and that you're doing well. Were the resolutions adopted by the IWG ever formally submitted to the Board of Supervisors, the mayor, and other agencies to which the IWG has reporting relationship?
So I requested Sarah to draft a letter with me as acting chair to submit them with some changes in her life and that we were not able to connect on that. So what I've asked is that we include them as appendices to the progress report and submit it to your appointing bodies together. So
Seems to been a long delay.
it has, yes,
In this process.
yes, yes.
So even without the resolutions having been formally sent to the Board of Supervisors, published, it seems like this is, today's the first day that fire is officially presenting to us on STIRT. So did the message get to fire or how did that?
I co-presented, I think, last year with Kathleen.
Oh, okay.
This is the first time we've been here independently.
Good. Okay.
And we lost 2 members to bio breaks. We can't vote on the minutes yet.
2, 3. Oh, we need one back.
Well, we're kind of ahead of schedule. We could trade water for a minute. Aha.
All right. Jamil, do you have any? I'm grabbing you as soon as you walk in. Did you have any thoughts about the minutes or were you okay with the minutes? Oh, just the ones we sent out before the meeting. No, okay, thank you. So we're gonna vote, folks. Chair, are you ready to vote?
Do we have to do public comment? That's what's next on my
Yes,
handy
ma'am.
dandy.
Oh, my goodness.
sheet.
Yes, public comment. Thank you for the reminder. There's no one here in person. So members on the public who are either online or by phone, and you wish to provide public comment on the meeting minutes, you can either raise your hand if you're online and Kayla will call on you, or you can join by phone. If you're participating by phone, please press pound and pound again, then dial *3 to line up to speak. A system prompt will indicate you have raised your hand. Please wait until the system says you have been unmuted, and then you can begin your comment. Haley, do you see any raised hands?
I do not.
Anyone on the minutes? I'm sorry, anyone on the phone? No. Okay,
All right, we will now vote to approve the October 2023 meeting minutes. Do I have a motion to approve the minutes?
I move that we approve the minutes.
thank you. Haley moves,
Second.
Lipton seconds. Great. Okay, I will now call roll call and ask each member to vote yes or no. Are you ready? Member Fields,
Yes.
Member Gonzalez,
Yes.
Member Hammer,
Yes.
Member Lipton,
Yes.
Yes.
Member McQueen, we are voting on
On the
the,
minutes?
on the minutes.
Yeah, yeah.
Okay, Member McQueen, yes. Member Patterson,
Yes.
you, Member Salinas,
Yes.
Member Wong.
Yes.
All right, we have all yeses, so the meeting minutes are now approved. So we are moving back down in our lovely agenda to discussion item 3, which is the SCRT update.
We are moving to discussion item 3, an update on the street crisis response. We welcome April Sloan, Section Chief, Community Paramedicine Operations with the San Francisco San Francisco Fire Department. And I see that you also bring another guest.
Mike Mason.
Chief Mike who?
Mason.
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 Chief Mason is in.
Thank you.
Could you come here? Yeah.
Please,
Tell you what,
please.
I'm gonna move. You have place? Okay.
Can pull up one of these other chairs.
You have to move down the chair and start. No, not you, not you. Yeah, if you would mind moving down.
So that you can come to the table. You sound.
I bet.
So that way you could be spending all over.
I need the outside.
How'd you send last week?
Yeah.
I think it's kind of.
So can we go to the next slide, Keely, please? Thank you. Take it away.
Thank you so much for having us. Chief Hank cannot make it, so I'm probably not as polished as he would be. It was pretty short prep, but I was one of the captains in 2020 when Street Crisis was launched, and I worked very closely with Angelica and Kathleen, so this is all material that's pretty well known to me. If I get too ready, then you might have to tell me. So obviously, we're here to talk about the reconfiguration and the changes in our program. What I want to say about that is that when this program was conceptualized and visualized, it, in response to George Floyd and alternative law enforcement, absolutely the right way to go. When we ran into challenges was implementing a response into a 911 system that forced us to reevaluate things for operational efficiency, speed, workload, ambulance. So when we first started this process, we were taking calls directly from law enforcement, meaning that the calls would go to the radio, straight over to street crisis, and then the plan was to switch it over to EMD, emergency medical dispatching, and the CAT. Within that, we ran into some challenges with PD. So as of 2022, is now removed from all 800 Bs. There are 25 cars for our first time. When street crisis is not available, or the response code is not appropriate for street crisis and ambulance goes. So that resulted in about 12% of the calls going over to the ambulance. And while they get to the hospital, they're not getting somebody who is able to give them like a complete like biopsychosocial assessment. So that's the ideal. It was causing some increased load on the EMS system unintentionally. We needed some more flexibility with staffing in terms of we were not able to, with that increased load on the EMS system, we were not able to go out without a clinician. And so we were not able to handle the calls that we were supposed to be assigned to, and ambulance was taking the overflow. So those were the big drivers on that, was that we needed to be within the 911 system, be operationally efficient, make sure that the calls are getting the right response, and not impacting EDs and things like that. I think I got ahead of myself. Next slide.
April, can you just clarify what EVs are?
Oh, emergency departments, yeah.
Can you switch slides, please? We have to talk to a person in the sky. Switch the,
Okay.
in the ether, in the ether.
It's like Siri, so it's Kaylee.
Okay, so obviously the team now it's a community paramedic. So a paramedic is, someone who's either got a 18-month certificate or a degree, emergency medicine. They do have some basic mental health training. Once you come to us in the CP division, they have to have a minimum of 3 years of experience. They have to apply, they have to want to be there. We do an interview process. We do another 240 hours of training on behavioral health, trauma-informed care, care coordination, all kinds of subjects, in order to get that behavioral and trauma-informed approach that we want to see. And again, these are people that want to be here, they're motivated to work with the population. They know very much that they're going to be dealing with people who have substance use disorder, behavioral health, and primarily experiencing homelessness. So that is, what they want. We thought that the clinicians, in the course of taking the calls in 911, a lot of it was, it's really hard for a clinician to engage with somebody in a lengthy manner in 911 system. So a lot of the people, we can solve the immediate crisis in shelter or door, or, that they need some level of follow-up. So our hope was that would happen with the clinicians, that we would be able to provide more intensive, not in 911 environment, where we're not able to stay on scene or do it on the street side, or, in a less than ideal place. But to sort of match their skills set in our strengths and combine them as much as we can, but still be practical and operationally efficient. Next slide, please. So the big question is changes in the numbers, or if there have been changes in improvements. So here it is. I do want to say, when we were staffing up, we were having probably about 5 units up per day with the previous configuration. Now I average 8 or 9. We handle roughly about the same number of calls. Our response time has improved dramatically. We're spending the same amount of time on calls, just about. We return to service more quickly. And the really nice thing is that we are engaging more people, because our unable to locate rate, that means when we get a call and nobody's there, is lower. So we're finding people more often when we get the call and we're engaging with them. Questions about these?
Can I do the question? These are numbers for street teams, not just Skirt, but all street teams, or is this just
So
for Skirt?
The first pre-configuration is street crisis, and the post-configuration is street crisis and street wellness. And so one of the trends we observed when, and the other thing I want to say about street wellness is, one of the trends we observed is that street wellness and street crisis had similar outcomes, and they do not have a clinician on there. I know there's concern about street wellness not being behavioral health, but I would say that it is, the intention for that also is to be an alternative to law enforcement, and that population that needs the well check very much suffers from substance use disorder. They have behavioral health issues, and they're homeless. So I do feel like it falls into what you guys are trying to address. So,
Can I add some clarity to that, or to additional information? Pre-reconfiguration, which occurred on March 4th of this year, the fire department had 2 teams, street crisis and street wellness. Wellness being focused on well-being checks, well-being checks that were previously handled by police. Post reconfiguration, there is no longer a street wellness team, and there's only a street crisis team, which handles both of those call types. Okay. So these pre-reconfiguration numbers are just our street crisis team. And post reconfiguration are also street crisis, which absorbs some more units from our
So
system.
just so I got the nomenclature down, to street crisis being Skirt teams.
yes.
Okay, just so I get it down. How often when you have a daily call for service, is there a coupling of a Skirt team and a rig?
So that would be the average engagement right here, 77%.
No, when you get a call,
Yes.
how often
Is
do you send a rig?
You mean an engine? You said-
Yes, an engine.
Oh, they're coaching calls. We don't get engines.
No?
No.
Okay, but in a typical paramedic call, you
An EMS
often
call.
get, often you see
Right.
an
So for-
ambulance
so
response
for-
and a rig.
Uh-huh.
Yeah.
Right, so there are some dual dispatches for SCSD where it's ambulance and street crisis.
Okay.
And so the ideal is that street crisis can identify that there's no acute medical psychiatric, and we can divert them to a more appropriate destination for them.
I know that I'm in the South of Market area,
Right.
but we have a constant intervention 35 in our neighborhood all the time because there are fires. we're talking primarily set fires, because of homeless encampments up on Harrison and also down in Essex. I'm just curious how often, when you got whether it's a homeless fire or something that is related to a behavioral health event, you have a fire response followed by a SPRT team response, so that there is a response on the scene.
That's not our current workflow, and that would probably be something to look at in terms of, but I would say most of the encampments are already reached by HSOC or the Tenderloin GFO or Street Med. So they're not lacking in response for behavioral health. But if you wanted an immediate response right after a fire, that would be different.
Okay. I was just curious in terms of whether there's some connection between when you got a fire call.
We do respond.
That might be behavioral.
We do respond to special calls from both the ambulance
Yeah.
and the engine for any kind of behavioral health stuff. They will call special calls street crisis.
There are other questions? Oh, yes, interim chair.
What is unit hour? Can you, just to make sure I'm not,
Time on task.
okay,
Yeah.
so per hour,
50% of the time, 54% of the time they're on task.
they're on task, and then the rest of the time you're driving, waiting for calls.
That number includes like driving to post.
Includes getting service in the morning, getting your narcotics, checking your rig, your medical, coming up on the air and telling B16 that you're available, driving to pick up your peer down here or your specialist down here. And then you go to service.
And UHU is a nationally recognized performance measure for EMS units.
And what number do you use as a sort of benchmark?
That's an excellent question. I could give you our UHUs for our medic units are in the 0.4 to 0.45 range. And that is a healthy, we're one of the busiest EMS systems here in the nation. So this is a healthy measure. Our units are extremely busy. And Hallie, Dr. Hammer, I'd be happy to provide that to you. We could come up with like a national average or a state average for comparative.
I just was wondering if how these numbers compare to your general. So it sounds like they are very busy.
Yes, how do you determine when to bring the SCAR team?
So that goes through GEM. Everything goes through 911 or 311. And the call taker identifies it as a site call and there's no weapons, no violence, they're not hurting somebody else. And they determine whether, then they send it over to dispatch. They send it us to get dispatched.
Or if this somebody that's dealing with mental health?
So yes, if they identified a mental health complaint, like say someone's out on the street screaming, or there's somebody sobbing, or I'm suicidal, but I haven't actually tried to harm myself, those calls will go to the dispatcher, would identify them as appropriate for street crisis and send it to us. Yeah.
They have to have no means of harming themselves, right?
Well, so no, we did a lot of training on this. So 25 is the card for psychiatric. Then you have suffix of that. This is all very different. But we have to pay attention to our WB and B, weapons, violence, or both. So we will take wobblers. So when somebody says, somebody's like maybe running around and they're agitated and they have like a bottle or a knife near them, but they're not brandishing it, they'll take it.
Oh,
That requires us to screen it. Yeah, that requires us to screen it carefully. And that's what we train our people on, is to sort of do a risk assessment. Is this something that we can safely handle? And even if they decide that, they may still take the call, but if they decide that there's too high level, they can special call PD if they need it. But you'll see in one of our later slides that we rate that, which we call for PD assistance, actually really low.
Okay, just as a clinician, we've been puzzled sometimes when does SCIRT come out and then all of a sudden police comes out, when we call. And so we've been wondering.
Yeah.
Okay.
Yeah.
Because sometimes we're expecting SCIRT and then police. shows
And that's
up,
always
we're
something
wondering.
you could either send to me, because a lot of times I work with DN about like, hey, how did this call get to street crisis? Like it's either inappropriate or not appropriate, or so you can always forward that kind of stuff to me and I can take a look at it and see like what happened there.
Why
Why things came instead of, yeah. And I've actually given, some of the, social work and stuff like that, things script teams for calling 911 so that you get the response that you want.
Yeah.
You know?
Do you call 911 or do you call like the dispatch DM yourself? Like
We typically are calling 911 because it just seems faster,
Right.
easier. And then sometimes we get skirt and sometimes we get the police. And we're wondering what was the magic word we said that triggered.
Yeah, I mean, I think I haven't worked at radio, but I think it's just a decision tree, right? So
Yeah.
you answer one question, then it's an if, and then, you know what I mean? So if,
It's a really,
I mean, if you do say like that magic word, then
Yeah.
whatever. it might
Because
be.
they've been definitely in situations where there's threat of harm to self.
Yeah.
And then, yeah, and then we're not sure, you know,
Yeah.
there was a weapon, there was definitely a thing around, and we're not sure how to phrase it to get skirt.
Have you ever just asked for skirt?
well, they discourage that.
I
They don't like
I
that.
have before actually, and they're like, no, you said
Right.
she had a knife, so.
But, and that's really just something safety, like, we want people to, go through that screening process for the safety of our crews, like, that helps keep us safe. Also too, so sometimes we have somebody who's like harmed themselves, that's gonna be a medical response, they have to go to the hospital. If they already, if they've taken pills, if they've cut themselves, something like that, that's not something we can divert over to your urgent care or,
Yeah, that definitely needs a.
Like, excuse me, but boy, it's really hard to, this is why not being at the table, it's hard to jump in and ask. So I'm just going to rudely jump in and out. And this is Steve speaking. The acoustic's really terrible, and I apologize for this if you've already said this and I couldn't understand what was being said, but what I'm missing here is the engagement with services part of the intention of the SCIRT team.
that is the next slide.
Okay, because actually, you know, mental health SF is as much concerned with people engaged in services as whether they had a knife or not. So I'm interested in the very low rate of engagement that the former SCIRT team had, not necessarily inappropriately, I would add, but a low level of actual connection to services. So we're going to get to that next,
We will.
which is the vast majority of people needing help on the street. And I always get concerned when we talk about guns and knives and danger. A lot of people are just really in need of treatment or services, and whether they know it or not, what we may have lost or what we may have gained with this new configuration of the SCIRT team that has eliminated the participation of the behavioral health person on the team.
So we're gonna go to that slide. So Steve, that's a good question for the next slide. Amy, you
Yeah,
have-
okay. Thank
You
you.
have-
This-
It wasn't a question, it was just a comment that just based on what Chief Snow was talking about, you know, is that I think the training and then hearing what member Salinas was talking about is that, you know, when we said, you know, oh, there was a gun, knife, or whatever weaponry, and then the police came, so it's also the training. I wonder, you know, I'm not saying that it's inconsistency, but it's just based on the people who are being trained, people kind of receive training differently, that's why.
Right.
Yeah, and
Yes.
that's, you know, even the phrases, so I think
Everybody's perception of.
it's different, so that's probably why there's all these different responses. And so wonder if the training, how can we try to even do it a little bit more consistent on across the board so that when, you know, I know you said you gave a script, but I think still, I mean, I don't know what else.
Number one.
I'm just going to preface by saying I think you guys are the heroes of the city, and having been recently had a recent service from a response. You guys are fabulous. And I think the fire department's a.
Yeah, I didn't you guys did that much.
I have one final question on the calls for service. And I know that this may have been addressed in the audit, and I don't recall, but is the track, and this is maybe more of an issue than it is a fire department public health issue, than a fire department issue is, how do you track repeat visits? And kind of, you know, what that data is, and
where that data goes, I mean, what's done with it?
So I'm just gonna speak to it briefly because we can maybe get into that at the end because it's not.
That's fine, that's fine. If you want to hold that till
Yes.
later, that's fine.
Yeah.
Okay.
All right, moving on. Kayla, can you advance the slide, please?
Yes.
Slide 2.
Yeah, so this is the service connection rate that Member Fields was asking about. Ours is slightly higher. What I would need to point out about this is, so when we take somebody to the hospital, which is 25% of the time, that is not a bad thing in our book. That means that person got an assessment by a paramedic, and the paramedic identified that there was an acute medical or psychiatric need that could not be triaged to another place. So that is an appropriate use of the ED. The alternate designation is 21% of the time, so that sheltered or urgent care, Soma Rise, sobering, MXM, those are some of the destinations. And then our services are voluntary and 52% do remain in the community.
Any questions? Next slide.
So 5150 holds. You can see we are writing slightly more. The percent of encounters resulting in a hold, the reason those numbers look like that is because we've taken on a bigger pool that is not strictly behavioral health. So those well-being checks, which are also intended as an alternative to law enforcement, those don't always have the behavioral aspect that might require us to write a hold. So, but we are still writing them in about equal numbers and appropriately, and you can see the numbers are fairly similar. We still meet with DPH every 2 weeks and review and get feedback. We do ongoing training. We're anticipating doing some training later this month on SB 43 on how to incorporate substance use into our 5150 criteria. So looking forward to that.
Question?
No, I was trying to.
Yeah.
I mean, sorry, go
I
on.
just, I'm sorry. I had one, I wanted to see if I heard it correctly in the first part of the report. The post reconfiguration numbers include, I think I heard you say that the wellness team had been folded into the SCIRT team.
So street crisis now responds to 25 and 32. So that's psychiatric and well-being checks.
Right.
Yes.
So these post reconfigurations would include more individual. Well, I guess your numbers showed actually the encounters dropped a little, but it's the mission of the two different interventions folded into one mission.
And I would argue that that the population who need well-being checks suffer from the issues that you want to address.
Yeah, and I'm suspecting that the grave disability number is higher.
Yes,
but
and
because of that intervention, yeah.
grave disability is, I would say, often a harder one for us, or one that we spend more time building a case on. So somebody, we might see them the first time and give them the benefit of the doubt. But when we've repeatedly encountered them and they're not able to provide for shelter, food, clothing, then we're able to actually do that, because we do need that sort of collateral information to provide to the hospital to make them willing to even consider admitting that person.
Do you have any information on whether the hold results in a hospitalization or not? Or are they maybe kicked out of the emergency room the same day they're brought there? Do you have any post?
I can address that at the end of when we come to frequent users again. So.
All right, thank you.
James?
Yeah, I was just gonna see if you could kind of explain what grave disability is and how it's, how you quantify it versus how you don't quantify it, or the people on the SCIRT team do.
So you're not, I mean, this group obviously knows what it is, but.
Well, I mean, I don't think everybody does.
Yeah,
actually.
I know, you guys
Yeah.
don't, okay.
No.
I think some of us know very well and others are.
Yeah.
Oh, okay, so the very basic definition would be the inability to provide or plan for food, shelter, clothing, hygiene. We very much look at it from a 911 focus, and that I would say was sort of a difference with the clinicians, in that, we find people naked in the community. To me, that means they're gravely disabled. If they put clothing on, that's great, but the fact is they were not going to go find clothing until we showed up there. Also, if somebody is living on the street, like say in a wheelchair and they can't move, and they depend on people to bring them food and water, and they're accepting, that's great, but that person is not able to provide for themselves, nor do they have a plan to go inside to the shelter. A lot of what we encounter is such severe paranoia that people won't go inside, and it ultimately ends up in us placing a hold for various building because they're not able to access services that they need.
I think that last example you gave also very much puts the connection, because I think also the way we learn about it at school is also an addition. It starts with you're not oriented to person, place, time, and situation, which then leads to the lack of inability to provide food, shelter.
But most of the people can pass, like a lot of time, there shouldn't be most of it.
That's
There's
the
capacity,
problem.
there's capacity, right, there's capacity versus orientation. Just because you can tell me, your name, date, where you are, that does not mean that you are necessarily capable of making other reasonable decisions. If you can't repeat back to me that if I don't change my wet clothing and it's gonna be 40 degrees tonight and you're likely to get exposure and maybe die, then I'm gonna do a little more exploring about your capacity and level of understanding as to, consequences of decisions,
This is a really interesting discussion. I think it gets at the heart of why we had questions about the clinician not being on the team and the reconfiguration. So it sounds like there's the number of holds placed per day is increased by about 10% or a little more. And it sounds like that may be because of people being more likely to be deemed with
There's,
great disability.
yeah, and to be clear, like DPH provided great training. I totally appreciate it, and I'm looking forward to the December. I've been in medic for 25 years. I have very strong opinions about what it looks like in a clinic versus what it looks like in the field. And I very much want to apply that because that is what I see on the street, is that it's not okay to let somebody go who cannot provide for themselves, or they're clearly delusional, paranoid, thinking, running around because somebody's chasing them. That is not okay to let walk away. We need to be able to engage those people and get them to care. It is difficult to do, but that is the right thing to do, and that's what we're trying to do.
And do we know whether anybody's doing any sort of evaluation using clinical data to know whether this reconfiguration is beyond the just initial engagement, that data that you're showing us?
It's a long-term.
Whether- Yeah.
So that was going to end, but DEM is working on, and Mike was very good with Stuba Astrid. And so one of the things we used to have prior to COVID was humps. So the high users of multiple systems, where we kind of identified all these people and worked on care coordination plans. And we were very much part of that. It sort of fell by the wayside, and we started to bring it back in about early 2022 with SCRT, because I was like, oh, now we have high users of street crisis. Now we have high users of ambulance. How do I, what are the commonalities? How do I stratify the risk? How do I connect these people involved in care coordination? And so DEM now, and we talked about it and identified this in the audit, all these silos. So they're going to bring together, the fire department, best neighborhoods, conservators, like all these people, so that we can kind of look at the long term, like, oh, they've been, utilizing, because for us, like when we see people utilizing like 911 and EMS, they're pretty disorganized and they're really in a bad place. Like that, it's a pretty high level of crisis, as opposed to somebody who lives in a tent who's providing some basic shelter. And they are very vulnerable and they need outreach, but we need to prioritize the most vulnerable and the most at risk of dying. So DEM has a big project, Mike can probably speak more to that, but they've been reaching out to us and all the agencies and sort of gathering information on how to identify and prioritize, and it's really been a really good collaborative process, and I'll be really excited when you can run a list and work on it.
And I think Dr. Hammer, you're asking the absolutely the right question, which is which is core question we always have, which is what is the longitudinal outcome of folks that we bring to the hospital? And I want to recognize our colleagues in the Office of Care Coordination. We have an automated data system where every day, every single person that we see is their name and all the information about our encounter with them is transmitted to the Office of Care Coordination. And they've been, there's some slides later in this deck. So that is very much a goal that all involved agencies are working towards. And as you know, maybe better than most, that is also a very challenging goal to reach. Integrating those data systems to fully understand trajectory of care.
I think that, this is a fascinating discussion because it's at that edge of what's voluntary and what's involuntary. And, we historically, of course, we only just now are working through the legislature on changing the definition of grave disability. Under the LPS Act, it remains the definition that has been utilized for 50 years under LPS. And it's the least likely 5150 hold to be reasserted under the 5152 or 5052 72-hour hold. So I think this is that nexus of somebody who clearly needs help but is not recognizing it or not wanting it, that may not hold up in current, judicial advocacy-based continuation of an involuntary hold. That the most work I think can be done around helping convince people to go to treatment rather than necessarily go into the emergency room and then have the 5150 hold dropped because no one sees it being continued under a 72-hour hold. So, this is the kind of intervention I think we envision. I know when the bill was being written, when MHSF was being formed, this is the kind of opportunity for having appropriate services and opportunities for people who need help but don't necessarily fit the criteria that has existed for years for an involuntary hold past the original 5150. So I think, this has a lot of possibility for being an intervention model that has, say, some of the care court concepts behind it, the possibility of a brief 5150 or the possibility of a longer engagement connection to services in the community. And that's why I'm particularly interested in the impact of not having a behavioral health person on the team at a point where we're convincing somebody that going into treatment would be the best way to address what appears to be a grave disability issue can be optimized. So thank you for this data. This is interesting.
And we have 4 more slides to go that have to do with various levels of impact and so Steve and Pat and then Mr.
I'm wrapping my head around the numbers, and I don't know if and I may not be right. I think that we have, you're saying you're having about the number of calls a day, I think, run to about 1,200 a month.
In September, it was 17. I have it up. It was 17.
It was the previous slide.
Oh,
Oh,
the previous
per
slide.
day, it was like 41.
Yeah, about 41. So that's about 1,200 a month. And we've got about 16, 17% that are unable to locate. So let's just cut it by 20%. For now, it's been a little south of 1,000 a month. In the last session we had with the department, it said in September, the fire department said 206 total clients to OCC. But you just mentioned that
Everything.
they get a daily.
Oh, yeah. So there's, we export the information to OCC.
Yeah.
To POET, the Post Overdose Engagement Team, and to HSH.
There's more stuff that's coming with the referrals.
Yeah,
All right, so I want
They
to
address
come
that.
back. I just want to figure out what, I think it's Steve's question also, how we're feeding people into the system and whether there are gaps or not.
In 2 slides, we're going to get to those things, then we can circle back. But
Okay.
Anderson, you had a question?
Yes, I like what you said about it's not okay to leave somebody on the street who has a grave disability. But like, what if the person is unwilling to leave, like everybody, and I'm not trying to justify what the guy did months ago when it was raining. I think that was horrible. But I also think, it's a situation where a woman was camped out in front of his business and was unwilling to leave.
Oh, I know exactly what you're talking about. Yeah.
And so, my whole
That was
thing
awful.
is,
Yeah.
it was awful, but it being solution orientated, there's a lot of people like that. They
Yes.
they don't want to leave the.
So that's a huge barrier for us. Also, in particular, PD has changed their use of force, you know, rightfully so. Those people are not doing anything criminal and they're not threatening anyone. So there's no reason for them to go hands-on. And honestly, we're not trained to go hands-on first. And if they are upright talking, it's a challenge. You know, it really relies on us like employing some verbal skills to try to either talk them into the ambulance or targeted outreach. Like we know this person is, you know, needs great facility and trying to find them in the moment where we can make that effective intervention. Those people tend to be pretty high up on the radar in terms of like with the various teams like Best Neighborhoods and everything else. And we tend to have a lot of coordinated efforts with them, and that like Best will, you know, do some active engagement and then they'll decide the person meets criteria for the hold. They call one of our captains. We come out, we coordinate with the ambulance, and we try our best to get them into the ambulance. That is actually like a whole subject. We have it in a high-risk 5150 meeting with the city about how to overcome some of these barriers to get people care.
I think this relates to the next slide, Kaylee.
Kaylee, yeah, there you go.
Okay, yes. So pre-configuration, we asked for PD a little over 2% of the time. Now it's 1.28. So most of the time we're calling for assistance with restraints or scene management. Scene management being sometimes we want them to like sort of secure a perimeter for us or something like that. If we have somebody who might run into the street, we want to make sure that they're not able to do that. Or if there's a crowd or something like that. And then restraints are usually something where we plug the immediate, it becomes obvious that we're going to end up getting physical and we want back up right away. So, but that doesn't happen often. So.
Next slide, Kaylee.
So the alternate destinations, where do we take people? These are the top ones here. So Door, Hummingbird, West Side, Maria X, Somarise. We go to Somarise. I would say Somarise and Shelter tend to be our two biggest ones. And in terms of Shelter, I know it doesn't seem like a behavioral health intervention, but it causes people to call 911 because they're in crisis and they don't have housing. And just because they ask for shelter does not mean that there's not an underlying behavioral health component. It just solved the immediate crisis in the moment and it helped them stop calling 911. So there are a lot of requests for shelter. We have a daily bed allocation. We usually use up most of it. We have 2 beds at night at the navigation centers that we use. And Somarise, which sets aside some beds for us as well at night. But nighttime resources, shelter in particular, is a big challenge for us. There's really all that's available is a woman's place, Mother Brown's, and Somarise.
That's my mom.
Mother Brown's?
Yeah, she passed 2005. Yeah, that's my mom.
Yeah, we go out there. Fair bit.
Next slide.
Yes, so there was a question about like statistics and we still have access to them. And yes, so it was through SF.gov, TM, this is, and it's right up in there, the September update. I don't think they've come up with October one just yet.
Yeah, these referrals, as we talked about earlier, these referrals, we're going to put a link on the IWG website under reports and resources so that it links where you can find this again.
Oh.
Just noting we have Heather online, I know.
Oh, yeah, Heather is, yeah.
Some members had questions about some of what these like follow-up outcomes mean, what they look like. I don't know if anybody wants to reiterate their questions.
Because remember Lipton mentioned this is a big question. And Steve, you had a couple of questions which you wanted to address. Do you want to go ahead and ask those now?
Well, it's the same, sort of the same questions. And there are, one set of questions has to do those individuals who you can't place. But the second one but the first one really goes to those that you are able to place, or at least, and I'm thinking more here, not necessarily place for service, but at least referring to OCC. And I'm a little confused by the difference between referring someone to OCC and uploading daily encounter data to OCC.
And I found, like you also had asked earlier about like
So referral is one thing, like getting into service, referral. The other one is resolve. What does resolve mean? Because in the earlier today, we saw like this case has been resolved. That may be more of a Heather question than it is you. So Heather, like how things are resolved and then what the ongoing.
Thank you for remembering.
Yeah.
remembering.
And what is the ongoing care to make sure that the person is tracked beyond that? So I think Heather, those are probably more questions that are yours, because after that referral is, after the connection is made, then it's the OCC that's taking it from there.
Yeah, I can try to start addressing those. I think there is some crossover with fire on some of those questions. And I'm sorry that I can't be there in person with you all today, but it's nice to see everyone. So when we're talking about referrals, I mean, the referrals and this upload that happens are the same thing. So what we are receiving every single morning is a list of people who the street crisis response team indicated as needing OCC follow-up. So that's the 206 are that upload that we receive every morning of people who have been identified as needing OCC follow-up. In terms of resolved, I'm not sure if I am totally following that question. Is that
What is resolved in the community?
Yeah.
Oh, remained in the community.
Yeah.
That means they declined our services, that they had capacity, they didn't meet 5150 criteria, and they had the ability to decline, and so they remained in the community.
And if I can add to that, that's not always a failure either under that bucket, right? Sometimes someone activates 911 for someone who's screaming, walking on the street. They're engaged by community paramedics or peer support specialists, de-escalating in the community, and it turns out this individual is housed. They might have a mental health condition, schizophrenia. They were de-escalated and they continue on their way. So that's not always a failure under that category either.
Does that answer the question about remained in the community?
Well, you just said something earlier about, you had substance use. Like if somebody's drunk or something.
Somebody can lack capacity due to substance use, which would fall under 5150. But as a medic, if somebody lacks capacity, we are going to do everything we can to compel them to go to the hospital. If they lack capacity, they are not able to refuse services. And that can be due to substance use. It could be due to dementia, which also wouldn't fall under 5150. But that is our paths for like compelling people are 5150 or you lack capacity.
I think someone had asked this question earlier, and I think we were gonna try and come back to it, is around folks like the revolving door, right? Folks that you see and then you see again in the afternoon. And I think it does directly relate to how 5150s transpire once someone gets to the hospital, right? And that there is a differential. And then the reason why I mentioned the other LPS criteria is that we 5150 folks frequently because they are really unable to care for themselves safely in the community. But, once they're in the hospital, if they're perfectly willing to take food, put on clothes, they don't meet 5150 criteria actually. So it is incumbent on us as the clinicians to demonstrate, or we have to wait sometimes until somebody clearly is so psychotic that if they were offered food, they're going to say, no, I can't eat that because all food is poison. And like, I am not of this earth, therefore I cannot eat that because that is of this earth, right? And that's what actually is going to get somebody held actually to a 5250 and held. And so you're probably seeing a lot of folks that really are not thriving in the community, but don't meet aren't going to meet the standard for
admission.
Right.
They will meet the 5150 criteria, but not the criteria for admission.
And then given how impacted the PSs and ED, they're typically only going to stay. Sometimes we've had people literally 20 minutes later show back up at the clinic after they just went off in an ambulance. Like, what happened? So, and so how often are you seeing, and then so with Heather also here, like, how is DPH like bracing for, like, we've got this new law coming January, and we're so impacted, right? I think but I can't remember, what is it, SB 43? SB 43, we've got, I was told, like, I've been told recently that there's only a rotation of 2 beds in the inpatient at the general. Literally, there's only 2 beds in rotation. So, I mean, how are we, you know, because this is very much going to come down, like, folks
This
are
is
going to
something
be
we already-
expecting you guys to
Right.
like,
Well, so no,
pick up all these people on the
this
street
comes
now.
to the
Yeah.
different appliances like that. So EMS 6,
Can you move to the next slide, Kaylee?
yeah, this will wrap into the end, I think. Yeah, so EMS 6 creates street crisis response teams. So EMS 6 has always, their core mission has been people who utilize the ambulance or the engine excessively for whatever reason. And so that has been a captain level position. It's almost always substance use disorder, behavioral health, or homelessness driving those calls. But we go out, we find those people, we talk to them, and we try to redirect them to something more appropriate. So we have often seen, you know, the cycle, like people go to the ER and they're immediately discharged, regardless of what their complaint is. That has gotten much worse in the last year. It's something I spend a lot of time on in terms of talking to ED staff and saying, like, what happened here? This person clearly should not have been discharged. And I think it's going to have to come up to a city level. They are struggling with capacity. I think they're really struggling with some staff burnout. Those are not problems that I can solve. All we can do in the field is do the right thing and get them to the resource that's supposed to help them. We advocate heavily when we bring somebody in on 5150. Like either EMS 6 or the CP5 captain who's the supervisor of street crisis is going to go to the ED. They're going to talk to the doc. They're going to talk to the psychiatrist. Like that is the level of, for our frequent users, that is the level of follow-up we do. And then we coordinate with their care teams. We put notes in Epic. We do a lot of coordination to try to get these people connected to care. It's very, very frustrating to see people who are so desperately needing to have help, but just not acute enough to be admitted. You know, and it really wears on our team and causes a lot of moral injury, you know, to see that.
Absolutely.
So this is, excuse me, but so this is I raised the issue of, do you know what happens with somebody who may be transported on a hold to the emergency room under an involuntary hold, who's right back on the street within hours? So you said, no, wait for that, it's coming up, but you don't really have that data yourselves. A system
We
should
do.
have it.
No,
Okay.
we actually do.
Okay, so what is that number of people who are transported to an involuntary hold at the emergency room, primarily, I guess, San Francisco General, and then they're back out?
It's not primarily
within-
San Francisco General. There's 7 receiving hospitals here, or 9 in the city. And
Well, I know, I'm aware of that. We work in the crisis field, but I'm
Right.
specifically thinking of San Francisco General.
I would say San Francisco General actually is not as bad as some of the other hospitals.
Yeah, that's gonna be the best one. Like, what is it at St. Francis? I mean, that's what, you know, so I think we, that data is relevant to get from,
And
for
so
all the.
Mike has some from, we ran data to see how often we see somebody after any transport, and then how often we see somebody after a 5150, and you have those numbers there?
Yeah, and so some of the term we use is re-engagement rate. And Mr. Fields, excuse me if that's the incorrect title, I don't have it broken out this meeting by hospital or by holds, but I do have it broken out by paramedic primary impression, housing status. We actually broke it out by a few clinic destinations. These slides were shared several weeks ago by our Assistant Deputy Chief Simon Patty at Board of Supervisors Treatment on Demand hearing. So you're welcome to look them up on that hearing as well. But for ambulance transport, so I need to be specific about this data. This is for when someone has contact with the fire department ambulance. Percentage of incidents resulting in re-engagement within 72 hours. So for someone that overdoses, where we ran a filter which determines if the overdose, that's about 6% are re-engaged within 72 hours. If the primary impression reported by the paramedic is substance abuse, it's about 14%. If the primary impression recorded by the paramedic is psychiatric, it is a 14% re-engagement rate. Now, if we want to stratify that percentage of all incidents resulting in re-engagement, it's about 7.5%. So the fire department is seeing approximately 3% of individuals resulting in 25% of call volume. Right, so we're seeing the same folks we're bringing the same folks to facilities frequently.
But all those individuals are reported to OCC.
So for the way the data systems work, I mean, one, we should say that all these individuals are presented to a hospital or to a clinic. Now,
But they're uploaded.
the street crisis response team, the community paramedics have the option. And we closely work with Heather and her team. I'm very grateful their coordination. It is challenging and complex. They can refer someone, can kind of send that encounter to OCC, but they can also route that encounter to the post-overdose engagement team or route that encounter to the HOT team. They can also say, this was an engagement that actually doesn't require any of these teams to have follow-up. And you can imagine in the 911 system, there's a variety of incidents, many of which the paramedic goes, you know what, this doesn't require a team to do a chart review. And Heather's team,
Those tend to be out of county.
it's a lot of work to do that.
So just like big picture, I'm wondering for your staff, so go back 3 years when you had a hot team, you had alcohol sobering center. So now with these follow-up teams, so the SORT follow-up team and OCC, and then also new sort of destinations, Summer Rise, Hummingbird. I'm feeling a little discouraged, like hearing you say it's getting worse, like you're seeing more people.
Inappropriate discharges,
Yeah. Have all those new resources made any measurable impact for what your staff is seeing?
I do think so. I think Summer Rise is enormously valuable to us.
Yeah.
Sobering has always been a great partner. We still actively work in their managed alcohol program, and actually all of our highest users with AUD are there still successfully met. It's been an amazing endeavor for them to see.
But of course,
there's another reason.
I mentioned Hummingbird.
Oh, yes, we do Hummingbird. Anything that's very low barrier is extremely helpful to us. Where we run into issues sometimes is, I would say, like, the people where we're bringing them, they have to be okay with. It's really hard to ask somebody who's been using stimulants to like sit quietly in the room and not disturb other people, and or somebody who's responding to internal stimuli to like not respond to it. Like you can't coach them to not do that. And so the places that can be more accepting of that behavior, and or maybe somebody that is get a low frustration tolerance, like those are the places that are most successful. So Rise, Hummingbird, their day drop-in is really pretty good for that. UBO project, actually, we go to fairly often. MXM is very good about most of our clients. So it's really like the lower barrier, the better. This is what is successful for us. And 24/7 access, really, because we're in service 24/7. Anybody else?
yeah, there was an intriguing reference to being able to cross-reference individuals who have encounters with the SCIRT team with housing. Are they housed? Are they not housed? If they are housed, where are they housed? In terms of what some of the difficulties are with our system, when you look at the parts that are very responsive to the incredible service you guys are providing, they're all short-term or repetitive. Summer Rise is not a residential environment for ongoing, it's episodic. And Dorigin Care is a clinic that needs to refer somebody somewhere. Even Hummingbird has a limitation on how long people stay and go there. So it's the next step after the intervention, the handoff to a crisis-oriented short-term intervention. That's the one we're still challenged with. And I think a high degree of the people we see who come through as repeat individuals at the emergency room, looking at our illusion that if you just have a hotel room south of Market, you're housed and that should support you. In fact, that very environment may be the environment that keeps repeating, particularly with substance use being a part of the profile over and over. And that we need to look at what we call supportive housing, has to be a more comprehensive and nuanced idea about how do you continue to offer someone support once they get through a crisis and end up right back in the environment that created the crisis in the first place.
We have about 10 minutes left on this agenda item, and so I'm wondering, some of what Steve Fields is mentioning and others are on this looking ahead. I wondered if you wanted to go through those and kind of just highlight how what those are and how those are going to start addressing some of these issues.
I will fully say that Simon probably had a lot to say about this. So what I'm going to say is, we were actually fairly pleased with the audit and the recommendations that came out. Just probably be a hearing in January, but we do intend to, increase our communication with like you and the supervisors and anyone else who's interested in the outcomes of launching. We very much want to be partners and coordinate care. And, like I said earlier, like all of us in our division, we like working in this population. We want to see the streets get better. We want those people to do that. And so, to that end, the street crisis, it's sort of like, it's always like an evolution, like, oh, there's a new service here, there's a new thing here. And so we keep integrating with all the different, services that we are offered, because I would say everyone, the DEM, especially now kind of coordinating, it's helpful to have them, they get information, from like FEST, where they get information and they disseminate. So there's definitely much more coordination and integration with DEM being able to be sort of like, overseeing a lot of it. And it actually ties into a lot of the, some of the higher acuity stuff, like the people that we see, street crisis is like this odd, like mid-level acuity. I shouldn't say odd, but it's a mid-level acuity service, right? It's very hard within a 911 system to have that narrow of scope, because traditionally you take what you get, and if you're not the right resource, you just handle it and get the right one there. So it's been a challenge to manage that. I do see a role for some of the higher acuity calls with our captains that we could take on. And to that end, we do work collaboratively with CIT, the division over there, when we have people that need that sort of co-response. And that's something we're kind of exploring as well in terms of getting the appropriate response to personnel there.
Can you, for everybody, can you say what CIT is?
SFPD's Crisis Intervention Team. So they're officers that have specific training in mental health and stuff like that. I touched briefly on Astrid. I think I'm very excited for that to have, be able to like generate a list that we can look at and be like, oh, this person has had like 2 overdoses in a week, so we need to go find them. And like, this person has, stopped. One of the markers that I pay attention to is if we have a street crisis client that is not, we can't do an effective intervention, they end up in EMS 6 client because we're no longer effectively able to divert them. That means we're only able to take them to the emergency room. So then they're utilizing the ambulance. So that's one of those things that we pay attention to because I want to capture those street crisis clients before they turn into an EMS 6 client. Shared priority is also part of Astrid, and it's one of the criteria that we're working on. And so some of that is our data, which is we include everybody who calls twice in a day, 4 times a month, or 10 times in a year. And then we've also added some other criteria, in terms of overdoses, HSOC engagements. It's a pretty broad, and so now we've had to realize we're going to have to prioritize and evaluate by risk. So that's sort of the ongoing for that. But Lauren Bell has been working on that a lot, and not exactly sure when it will be up and running, but yeah, I think it will be a really valuable tool for a lot of departments. And then mission alignment and guiding principles. We're here today to support your work and keep doing what we're doing, and open to feedback on, changes.
I'm super glad to hear about expanding the calls that you can respond to. I think it was one of the very.
I saw it in the resolutions that you guys were the 808.
Yeah, I mean, it was so specific and specific, and particularly when we were needing to call someone who's not police to respond to a situation with someone that has to present so cleanly, right? So
Very
cleanly,
difficult.
like there's no, and so that's very difficult. It's very difficult. And so it kind of sometimes prompts us to not want to say
Right. Well, there's
everything
also,
and give all the information, because then, yeah.
there's also one of the things to consider, like operationally, is like when somebody, street crisis can't go directly to a hospital. The ambulance, Title 22 says only ambulances can go to EDs. So somebody, when they're placed on a 5150 or they've actually tried to harm themselves, that gets an ambulance response. And that's why I try to make that a captain as opposed to street crisis, so I can keep street crisis and system responding 911 calls. Like you said, my captain, they can write hold, and they call the ambulance, and then everything's taken care of without having to, you know,
You got places can't take somebody to the hospital.
they cannot, they're not an ambulance.
No, I can take somebody to the
Yep.
hospital.
Is that something that should be changed?
It's Title 22 within the state, that would be.
I understand.
Under.
I mean, is this something up to the state EMS agency?
Yeah, it's very long established.
Yeah, I know.
Probably from like the late 70s.
Yeah, but it would be great to have skirt and ambulance respond rather than police and then they call the ambulance, you know, right? And so.
Yeah, and that does happen. The ambulances will special call us for, you know, hey, I'm here, this guy's suicidal, can you come out and evaluate?
It just seems that the explosion of street crisis teams and teams like street crisis teams throughout the state.
Yes.
I mean, everything is changing.
Mhm.
And also diverting people from emergency departments to sober centers and to other locations. And I just, you know, this is a state issue, but whether or not the state EMS agency is kind of behind the times. I mean, I remember the first time someone tried to open a CNU in, I think it was in the Central Valley. And they could not bring individuals, an ambulance could not bring someone to a crisis stabilization. And that was just not permitted. That was quite some time.
So the state now has AB 1544, which formalizes community purpose. And legally allows us to do.
Well, we originally had 0 C issues and now we have about 30, 40, 50 throughout the state. They've grown like crazy and they've been favored nation because the state is basically help fund. Just so many. So this is a statewide issue. So it'd be nice to see kind of a realignment.
Are there any final comments or questions?
I just wonder, since Heather was here, I mean, if she wanted to talk to the continued integration of skirt and VHS at all.
Yeah, thank you. Thank you, members of Leadness. I am happy to, I do have to hop off shortly, but I really want to acknowledge, it's been really helpful to hear, I think, the discussion and really appreciate our fire colleagues, street crisis response team colleagues for the continued coordination. There's I think great relationship building happening and integration happening around follow-up for street crisis response team calls. I think, and I'm wondering if it would be helpful for OCC to come back and do a focused presentation on the follow-up that we do. There's a lot, I think, to talk about in terms of our approach and how the follow-up that we're doing for street crisis response team is actually tying into our other initiatives and strategies like our 5150 follow-up and new best neighborhoods teams, which is coordinating very closely with street crisis response team and with the other street teams coordinated by DEM that were mentioned. But I think there's a lot that we could really unpack and talk about and a lot of really exciting work that we're doing. So we'll just put it out to the group to see if that would be something that would be helpful. And just to say that our OCC teams are doing, when we receive this data upload every morning, we have teams starting at 7 a.m. Immediately trying to outreach to people especially who are in the hospital and who are emergency rooms, who are at Soma Rise, who go to Dorichin Care, who are taking locations, immediately reaching out to those places to try to engage people. And then our follow-up teams also outreaching to people who remain in the community to try to engage and connect to services. So there's a lot of work that happens around there that we would be really excited to talk about.
Thanks, Heather. We're going to be prioritizing topics at the end of this meeting, so we'll definitely put that down.
And I know this isn't necessarily your purview, Heather, but maybe for like future for Dr. Kunin's updates, like, is there any consideration by DPH, because it's entirely up to DPH, and about reopening, say, 7A or 6A? I mean, we desperately need, we're talking about how many people are revolving through, are having these repeat contacts within 72 hours. And that's about hospital capacity, right? It's absolutely about hospital capacity. And so I think that who gets held for grave disability, how that works has changed over time, right? So we would be able to have someone held on a 5250 before for their inability to care for themselves. But now we have to wait until they're literally so psychotic that they will imminently die because they're not feeding themselves in order for them to be admitted. And so that's completely been relational to the hospital capacity, right? And so, I mean, and it's not just those units, right? It's the unit that was at CPMC St. Luke's, right? It was the units that we used to have at Mount Zion when that was a public hospital, right? And it was a unit that we used to have at St. Mary's that I didn't even know about till I worked with seniors. And then, 15 years ago, and I used to say, I used to love to go to St. Mary's. I was like, there was an inpatient psych unit there, so, I mean, so it's, our city has grown since 1994. And we have like less than a third of the hospital capacity that we had back then. So, I mean, this is and with SB 43, whatever, I feel like I blocked that out. Like, what's that going to be like? It can't even be, how is our hospital, so OCC is going to be working with those folks, right? And they get referred to us, we're already getting some of the clients from OCC for, in the ICMs. And so, but for them to even get to us, they have to be somewhat stabilized. Otherwise, they aren't even going to want to work with us. And that frequently takes
With you, it's about the
level
end.
of a hospitalization or some, to get someone on meds so that then there's somebody that's willing to actually engage with us, right? And I think it's not realistic to think that OCC and the ICM providers are going to be able to engage somebody in treatment that is on the street, using not on meds, completely paranoid of anybody that, walks within 10 feet of them. Like it's a tall order to put on ICM. I mean, we try it, and I think it doesn't happen until then we have to conserve people, and then we can get them stabilized, and then they can actually agree to go to, Progress House and to work with us, so, it's a trajectory. It would be nice if we started, I think that Steve frequently, there are all the folks that are willing, it would be nice to catch those people, 5 years ago when they were still willing to engage with us. But we have to tackle this problem on both ends. And right now, those folks are more acute. They're in more imminent danger of death.
So I think we need to move to public comment. So if you could advance the slide, Kaylee. There's no one here in person, but we invite those who are joining by phone or online to make comment on the street crisis response team discussion that we just had. If you are joining online, please raise your hand and Kaylee will call in and unmute you. And if you are calling by phone and would like to comment, then please press 3 or press pound and then pound again, then dial *3 to speak, to line up to speak. A system prompt will indicate you've raised your hand. Please wait till the system indicates you've been unmuted, and then you may begin your comments. So Kaylee, do we have any hands raised?
I do not see any hands.
Okay, we'll give that just a minute. And we are also, if people are deciding to raise their hand, we'll open it up to those who are calling in to dial 3 to line up to speak. Last call, Kaylee, has anybody raised their hand?
Yes, Sarah has raised her hand, so let me unmute her.
Thank you. Sarah, I'll give you 2 minutes. I'll give you a 30-second warning.
Okay, thanks. I just wanted to say I just was reading the annual report from San Francisco General, and they make it sound like they're doing all kinds of mental health things. Apparently have 5 different mental health program services and improvements, addiction care team, inpatient psychiatry, psychiatric emergency services, social medicine, Solid Start, and Team Lily. Over at the BHC, we haven't heard about any of these things. And I mean, if there's only 2 beds in rotation, this is just ridiculous. Yeah, they really do need to open up other beds. They're just not serving the community. That's all I have to say. Thanks.
Thank you. Anyone else on the line or raise their hands?
I don't see anybody else.
Hearing no further callers, public comment is now closed. Thank you so much for joining us.
Thank you so much.
Thank you.
Yeah, and feel free to reach out with any questions, follow up.
Greatly appreciate it.
Thank you so much.
Thank you.
All right, we're gonna take a 5-minute break and then we'll be back. So we're back at 11:12.
Thank you. I mean, we recognize Scott. I've had many emails with you.
Yeah.
And I had a
2023 progress report at slide 30. So this is what we presented at the October meeting, and what we presented at the October meeting, and it frames the purpose of the report and then the report approach. So at the last meeting, we brainstormed signals of progress and discussed some challenges and barriers. And so then I integrated all of that conversation into the report, and I got it out to you. I got feedback from a couple of you. Thank you so much, including that I included the old version of the SCRT recommendations, which would have been really bad. So appreciating those of you who looked at that. And then I made line edits to the report, and I submitted it back to you or Kaylee did. We resubmitted it back to
The website been updated?
Yes, the website's updated. Yep, all the recommendations are correct. Thank you. Appreciate that. So members of the public, the draft report is found on the IWG website as part of the online agenda under that agenda item. Next slide, Kaylee. So today what we're going to be doing is I'm going to share the screen and we can go through the changes and just kind of verify that the changes, everybody's okay with the changes, talk about anything else that needs to be done. And then the majority of our time, we want to just be talking a little bit about what the aims and goals of the IWG are for 2024, so that we can note some of those in there. So what I'll do, I forgot to, hey, Kaylee, can you go offline and grab a copy of the PowerPoint? I'm so sorry. I was thinking that I could share my screen, but I'm actually not on WebEx.
Yes, I'm looking for the report.
Yeah, so if you stop sharing screen, forgiving like commercial break. Yeah, if you go to the deliverables folder and go into progress report, number 3.
Okay, hold on.
And then there's a V2, version 2.
Oh my goodness. Okay.
I can actually.
Is the PDF version okay, Jen? Or do you want the Word?
I think I want the Word. Here, I'm going to Slack it to you.
I just found it.
Oh, you did. Thank you. Sorry all about that.
No worries.
And thank you, Kaylee. You are always so chill under duress.
Trying to open it. Oh, here we go. On the desktop version. Sharing.
Yay! Thank you so much, Kaylee.
Of course.
I appreciate that, and I appreciate all of your patience with me. Got this up. So what I thought we would do is just go through the different sections that were added. And unless you've all looked at it and you're like, yeah, we're fine with it. So would you like to go through the changes as they have come up, or do you just want to focus on what's next? What our goals are for 2024?
I'm fine with moving to what's next.
You fine? Okay. Anybody want to hang out on what was changed? Okay, so we're just gonna. Well, after all of that, Haley, we're good to go. So thank you. But maybe let's go ahead and talk about so in 2024, what is it that you want to achieve in 2024, and I can summarize that in the report. The aims and goals.
So what I like, what it seems like we're going towards, I don't think we're quite there yet, but I see it progressing, is, you know, a ladder system. So where somebody can go from, you know, there's a step, you know, somebody can go from homeless, from mentally ill to mentally stabilized, from homeless to sheltered, so that they should be housed and working and contribute to society. And I would also, and I'm starting to see this too here, even in a few meetings that I've attended, is just a diaphragm of the system. So people, you know, just have a map of where to go.
Yep.
And how the system actually works, where the client can see that.
Yeah. Works from client perspective, thank you. Okay, so, and you, I've heard you use that word before, the ladder system, which is kind of, I think, similar to the continuum of care, like those concepts all go together. And the steps from being homeless, having substance or mental illness to becoming stable and then contributing. And particularly for clients, as a map for the clients.
And then also the last part too is to and this is part of today too, but to differentiate from the client that's, you know, content, or the person that's content in just going through the motions, and the one that actually wants to get out.
Yeah. Yeah.
I think that's very important to establish. Yeah. And they're not all just the same.
Yeah.
I mean, just building on what Member Patterson said, I think in this next year, one of the things that I would like us to understand better, and I know this is all part of the sort of developing the metrics, developing the data, is that as Marlo shared, like we're getting, and as we saw in, I think as we've seen in all of our recent presentations, we're getting more data. But I think getting to that, what I think is like the true north, the North Star of for the population that's been defined, the hardest measure, like not, you know, the real concrete measure that I would like to see is how many of that population are getting housed, right? I think it's a little harder to measure how many are getting into care that's appropriate for them and effective, and are improving in their sort of mental health measures, but how many are getting housed? I would like to see more of those, what I think of as outcome goals, and not only the more, what I think of as process goals, which are that we did this thing for them, you know? But I think in the next year, we can start asking those questions of how do we know that all these things that are being implemented are actually making people more likely to be housed, more likely to be having their mental health or substance use treated effectively.
So measurement, North Star, and getting to outcomes, not just process.
Excuse me for one sec. I had to go do something else on my other laptop. Do you have the document up? Because my screen doesn't have it. I just have the step 1 review, step 2 discussion.
Yeah, the group decided that we were good on the report so far, and we're moving to discussing what the aims and the goals are. So we took the document off the shared line since we weren't talking about the content.
Okay, all right.
So right now we're on step 2 is what are the aims and goals of the IWG next year? The first being to continue to work on that ladder system, the different parts, you know, what the different steps are, given the different needs, moving people through to wellness. And then the other one is the associated data with that goes beyond process measures and moves to outcomes.
Okay.
Yeah, Jim.
Yeah, you know, I've always said since I've been around on this in my short term here. I'm a big believer in, what gets measured gets managed, and I think they're doing a lot better job of that. And as the doctor said, I'd like to see, what is the outcome? And I know you have patient confidentiality rules, et cetera, but if there were patients that were willing to share their success stories, I think, maybe looking at a success story once at every meeting, somebody could talk about that, and even if it's a pseudonym or somebody, like, let's talk about that and what went right from beginning to the end, and just kind of, I think it'll give us some momentum and some positive feedback to keep going, and then also build off of those. Okay, well, this is one went well. Let's continue to try to do that, and 'cause if it works for one person, it's more likely going to hopefully work for others. And then I've kind of been a big person on the Epic and the data management. I think it's getting better because, as you see, we can kind of manipulate numbers whatever you want. But if you're collecting that data and seeing that, okay, as April was saying, oh, we've seen this person's been overdosed twice in the last 4 days, et cetera. We need to go find them and really work with them and do different things. I think if you have that, like, one of the things that I was disappointed when I saw in Summer Rise is the data collection. And it's like, okay, well, who are these people? What happens to them? And, how many times have they been in here? What are their medical problems? Are we addressing those? I just think that really getting a hold of that and really being able to define that person, and okay, they've been seen 9 times in the last 3 months, and they're not looking for that help, and they can't, they are a grave disability, and then so like people can say, like, hey, we're going to go talk to the clinicians and the psychiatrist and the doctors at said hospital and say, hey, like, this is what's happened to them. Don't just give them like a 2-hour hey,
Wait to come back.
yeah, and then like the nurse is burnt out, but like, hey, they're fine. They're having a cup of coffee, they're talking to me normal. Like, let's go, let's clear the bed. We have 8 people out there. You know what I mean? So it's just, I think that doing that more and then having the more information, and I know that sometimes can be overkill, but I think it's kind of needed. I think sometimes it's too much, but in this case, I'd rather have more, and to be able to kind of make the arguments of, this person is a grave disability, because I can say in my experience, and I don't want to bring this up because I think they did a great job, that their average of 1.04 holds per day on the 5150. I could see that. I could go walk outside right now and see that we could probably do that for 25 people within a 6-block radius here. You know what I mean? And I hate the analogy, but I mean, sometimes we treat our animals better. We wouldn't let a dog on the corner be treated like that. So that's long-winded. That's my goal, is to see more of the success stories, more of the the soup to nuts, what's happened.
I think the success stories, I think that'd be a great way to start each meeting. And I mean, just hearing your quick interaction with April about a shared client.
Yeah.
Like, that sounds.
Obviously, it doesn't have to be names, et cetera, but I mean, like, to say, hey, we had a 48-year-old female.
I could bring in you could bring in, I mean, we know success stories.
It's like a 5 to 10 minute thing. It'd be like, oh, that's great. And I think it just gives a little momentum, and like, oh, okay, this is not a lost cause. It's not like all like, oh, dude, not doom and gloom, but like, here's well, we're not getting this, we're not doing that, like, okay, great. Like, so what went really well on that? And maybe just trigger some ideas, and we are a working group. Like, okay, wait, we never really thought of this, or we didn't know about that, or whatever it might be. What's that?
Nobody asks to say what went well. So
No, I mean, you got, yeah.
No,
Maybe that's starting in January, February, like, then somebody has, a 5-minute success story, like, all right, here's the, approve the minutes. Okay, first agenda, here, quick success story. All right.
For me, because like sometimes I don't know if it's bureaucracy or what, but sometimes people that work in the field, my experience, can be disconnected. But the person that's been through it, you learn more about the battery system, or what works and what doesn't work. The person that's been through the fire, so, and that's from my experience in working in the system. And I kind of still do work in the system, trying to help people find housing and all kind of stuff.
So we might be able to come up with some way to kind of rotate too. You're like, some of you all have examples of their own work.
Yeah, and I think for like folks in the EMS, you know, the EMS 6, like once they stabilize, you're not seeing them as much, so you don't know, like, you know, but like that's what I wanted to tell April, like, 'cause so they don't know what's happening with them, right? And so you don't get to hear that, you know, they don't, we work with them very closely when we're getting new referrals, right? But then then if they're leaky, and then they don't see them as much. And so then they don't know where they've gone, which I think would be particularly helpful for folks like Member McQuiggan, like, you know, what happened now
Yeah.
that you haven't seen the person
No, 100%.
in a year, right? So did you guys see them when they're really, really in their worst folks, in their worst places, and work very closely with you guys, you know, until they're stable enough to actually be engaging in the services, and then you guys don't see them. So you don't know,
Yeah.
you don't know where they're at, right?
So other aims or goals of an advisory body, like what other things would you advise on? The ladder system, definitely data, starting some things with some success stories that might kind of knock loose some ideas and celebrate what's happening.
But like,
Well,
Yeah, Member Fields,
Right.
please.
I'd, yeah, let me do anything quickly. There's success stories every day for those of us working in the treatment system. You know, they're every day. The problem is there aren't enough of them because we don't have enough of a built out, from my point of view, a goal should be built out community system of care. The MHSF legislation is clear and nobody was arguing with it that we have a challenge in providing and not having expanded our community system of care to prevent deterioration in someone's condition after we have invested an enormous amount of front-loaded treatment and care for people. And there's just no arguing with that. When we see somebody return to one of our crisis residential programs and we talk to them about what happened, they were in a strong place when they left the system of care, not just from us, but after us, after transitional treatment, if they have a case manager. But those things stop, or they fall apart, or they're not intensive enough in terms of where they're living or what options they have for early intervention strategies to head off a developing crisis. That's what creates that you have to be you have to qualify for 5150 to get treatment. That's a shorthand for what was wrong with the system and has been for decades. Individuals aren't doing great on Wednesday and wake up on Thursday needing to be 5150. That process deteriorates over time. And we have a serious problem with identifying what the continuum of care really looks like after acute care. We should not need more hospital beds. We haven't added to recovery-based services in the community in 25, 30 years. No new beds, except board and care and skilled nursing facilities, which are institutional or temporary. So I think the goal of the IWG should be to carry out the second and most important part of what the legislation called for, which is working with the department on identifying what the elements of a system of care that has recovery as its goal, that has supportive structure until people are ready for the housing that we develop, and that develops housing that's not assumed that our majority of our housing has to be in the worst neighborhoods of San Francisco, where the drug using has not abated and hasn't changed. So we still have an unfinished goal here. We can't afford to hospital bed ourselves out of the dilemma we're in. Those are short-term interventions that are needed. We need to identify what it takes to prevent someone from reaching the point where they're back in the emergency room. And that's not a mystery, but we have not invested in that part of the system in years. And we still haven't identified a continuum of care that would help maintain somebody's stabilization, identify when things are starting to go wrong, and allow them to access the system at a lower level that can meet their needs rather than have to wait for an emergency. That's not a mystery. We know how to do it, but we need to identify that system of care now as goal for the San Francisco behavioral health system.
Thank you. So that's building on some of the things that some of the other members were saying, the ladder system, the continuum of care. If you're really focusing and honing in on some elements about what happens after acute care. And
the holes in the system.
The holes of the system, yeah. Okay, so designing the ladder, finding the gaps, thinking about particularly like that next step of acute care and housing.
And Steve, I think you're talking about both holes from a physical structure side as well as from a care coordination side.
Exactly. We identify what we're trying to achieve, which I believe is meaningful stability in the community, meaningful opportunities when you're stabilized to take advantage of that for school or training or other things in your life. And we build a system that allows people to get there and stay there with minimum necessity for emergency care, then we will have identified what the community treatment system of care was supposed to be when it was envisioned back in 1969 or 70. And we still have a lot to do. So yeah, it's a conceptual, it's a goal-based, outcome-based system, and then it's putting in place the elements of that system of care that support people adequately at each step of the way.
And just came to my thing again to ask a question. I know how you were talking about housing outcomes, and Steve, you're talking about housing as well. I just want to remind everybody that HSH is supposed to be, it's named in the legislation as a contributing, like, consulting department for this body. Would it be helpful for me to start outreaching to them to plan for them to come back? I know they're doing some like strategic redesign of their, oh my goodness, coordinated entry system. They have a lot of sort of policy evolution happening in that department. And I'd be happy to try to get them to come talk about what data they have about the entities of priority population and what you're sort of their goals and insights.
I think that would be great because there's a lot of problems with people coming out of our treatment systems, making it in the coordinated care system when it crosses from the health department's responsibility to HSH. And I think I know Shireen McFadden recognizes that dilemma. And we need a supported housing model that is primarily housed in the DPH world because it needs to have accountability to the whole system of care. And coordinated entry has to provide environments that do not demand that you can live with a minimum amount of supervision in large residential environments. There's still a treatment element to strong supported housing. And I think that's what we need to work with HSH on, but within the Department of Public Health on developing stronger supported housing models that do not demand that someone go from an intensive treatment environment, whatever that may be, and then step down the next day in a minimally supervised, only a case manager modeled large housing unit where you may not be noticed as you're deteriorating for weeks. So HSH, I think, is open to that kind of collaboration, and I think it would be a real positive step.
I think in that regard, it would be helpful to do it as a joint presentation with the department. And it may be something that could require a greater time period. That this probably can't be reduced to an hour, but it also may be something that maybe some prep involving just a subgroup working with the department. HSH might be helpful in terms of trying to shape something for meeting.
But depending on what agent's capacity is, it could be a longer trajectory in one meeting. It could be kind of thinking through like a conversation that evolves over time.
I just think it's important. Steve, I think is right. I think think this is a very, very important issue, and it may have to be staged, as you say, but we should get in front of it and figure out how we are going to stage this.
Member Salinas and Patterson.
So, yeah, it was lots of things I want to echo, and that I was thinking, like, if we're going to get data, that maybe we should focus on what would have been the homeless folks. And then folks that are conserved, that are coming out of outside back to the community. Because I think that we're looking at a lot of times that those folks end up faring very, very poorly. And what is it about, you know, because I think that there's levels of care that don't currently exist that need to be created, right? And that is the thing that we need to work with HSH on. And I think that also that the data needs to be there to press it to the supervisors, because I hear like timing, like, you know, Shereen came up with a very excellent report and the projected amount, you know, dollars that are going to be needed to create the housing that we need to get to zero homelessness. And I hear many supervisors just laughing at that and not saying this is a ridiculous amount of money and we can just do these options, these cheaper options. And the fact of the matter is that the non-supported housing cheap options don't work, right? And they end up costing more money in the long run because then people are using emergent, crisis services, right? And so what you saved, what you think you saved in dollars that you were not willing to spend to build the appropriate housing, you end up paying for somewhere else in the system. And so I think it's really critical around getting the data to show when these folks move through the system of care, if they don't have the appropriate landing points, then it doesn't meet their needs, and then they end up not being successful in that level of care and end up decompensating. So you can't just decide you're going to chimp out on what, on HSH because it doesn't meet the needs of folks. And so we would need to really look at, particular populations. Because we can't measure everybody at any rate, so what would be the populations to focus on?
Member Patterson, and then I want to make sure we speak for Member Wong and Member Revolves. I haven't heard from you yet.
I mean, we should be able to have a realistic scope. I mean, today isn't the same as 1990s. Like where, there is a mental health situation going, is it growing, is it getting worse, is it getting better? And I think our systems definitely should be getting better. So, we definitely should have that analysis. And I say that looking at it from working in the homeless situation, or homeless field aspect of it. Because the homeless situation as far as people is getting worse because there's more drug use. It's more drug use than in the 90s. It's more kids on crack or they ain't crack, crystal meth and all kinds of stuff. And some of the scope can still have that 1960s approach, which is definitely outdated. So we need to see what's outdated, so that we can, our methods can actually fit the problem. And I would also say, just from working in the system, and this may be hard to do. But we definitely need to find those veterans that's still there. There was one guy, he put the perfect scope on what do they call it? They call it the drug use. They call it to where they kind of wean people off drugs. They have abstinence, right? You have those two approaches. And harm reduction, and abstinence. I'm going to land the plane here. he had the perfect scope. He was like, well, they really should work hand in hand. He's a 27-year veteran in recovery, drug recovery. He said, you know, the harm reduction can be like a fishing system to that person. When that window opens in their mind, they want to go to abstinence. And when the class unit was like, the system's gonna work. So I think those kind of innovations, and you get that from people that's been through the trial and error of the system. So
So I hear one thing is kind of forecasting what is happening with homelessness, substance use, being able to kind of see where things are going and then the responsiveness of the elements of the system to that. And the other thing that I heard was hearing directly from members of the community that are doing different things that may be abuse. It's more, is that kind of right?
or veterans,
Yeah.
People that's been involved, you know, in the nitty gritty for like 30 years. And there's stuff that you can't study in a book that they know. But then also like really the hone in is like what kind of system are we using and does it apply to the actual problem? Is it outdated?
Yeah. I just want to piggyback, on everybody. I mean, I think I have a very strong sentiment about using what we already have. That's always just been my model. And that's kind of piggybacking what Member Patterson was talking about. I mean, there are so many services and so many programs out there that I don't think I am aware of. And just listening to the chief today talking about, oh yeah, sending here, sending there, and I'm like, oh, I never heard that. So if we can just kind of also tap in, and we're so lack of resources, right? So if we can still use the resources that are existing and collaborate and extend, the services to work with those people or the programs that already exist, that maybe we can actually help also the transition, the maintenance. And I think if we always understand that housing is important, if we can just house somebody, I think a lot of stuff that are gonna be followed much easier. And very similar to everybody's statement is to be able to see where they go, the flow. And, that's so important. And then treatment. And I want people to be in treatment. How do we, engage and then have them be in treatment so that they can stabilize? And as Member Field said, we want to help them so that they can use the least amount of resources so they can be independent. That's what we want to be also optimally for ourselves as well.
Just briefly to expand on the idea of success and like what is success and hearing a success story, I think it's really important. Maybe as important as data, because data is really helpful to help us understand if what we're doing is working. But I think also, getting the impressions of the communities. I think trying to engage the actual communities, especially the target communities where a lot of the streets and stuff is happening, and there's a lot more sort of mental illness and substance use happening within, and just engaging members of the community and getting their impressions on, do they see that things are changing, since we've, implemented all these. Also, there's a client council. There is a client. Yeah. Anything maybe engaging them as well, and see how they see. And the big robot commission is also. Clients. So my messy notes are showing 9 different actions that relate to advising the system on the design, effectiveness, and outcomes of DHS. Is there anything that you hear to? What I'll do is, what I'll do is I'll write these up and I'll circulate them. This is due on the 1st, so we don't have a whole lot of time. So I'm literally going to spend this afternoon writing these out and sending them to all of you. And if you could please take a look at that and see if you agree, and I will, in keeping with how we have to do this, I'm wondering if there's somebody who wants to work with me, 1 or 2 people who would work with me in collecting these and putting them together. I mean, it's the next 2 days.
I'm at the fire station next day.
But all I will do for those 2, for whoever Like it's.
I can tomorrow morning.
Andrea, okay, yeah, because I can send them to you, and then like, what I'll do is I'll send them to everybody, respond to me, because we have to do this by Brown Act, so respond to me, and then I'm gonna contact you, Andrea. And I'm gonna say, here's all the responses, let's put it together, you're gonna be my partner in that. And if anybody else wants to join,
Jen, I would normally go through, I'm not a planet holiday.
okay. I can't even understand, you do it like 1 day or 2 days?
The first is Friday.
We've got 2 days, we got a Christ.
Yeah, I think, I don't necessarily, I will do it whenever it is.
Okay, yeah. So Andrea. Yeah. Okay, so I will contact you, you'll be my ears as I'm putting this together. Get all of your feedback so it's integrated, because that's what we'll be doing. And then what we put in, just know that like, we can still continue to work with it. So what we put in, like we come back in December and kind of refine it further and make a trajectory of how we'll get there over the next year.
I have one question, and I don't know whether it's
Sure.
to be in here or not. Is we have a fair amount of discussion here about challenges and whether we need to address in our work program, how we address the challenges. And the challenges that we mentioned are challenges of first membership. And the second one has to do with the shared understanding of the IWG scope. And I don't know when you say much, maybe you can just ignore it, but I just didn't want to go by without some
I don't know if we
conscious decision what to do about
I don't think ignoring it is what we should be doing, but I do think.
it. No, ignoring it in the report as opposed to.
Yeah. Well, I think, I don't know, I'll leave it, it is your report, so I will leave it to you. My impression from being someone who's walked alongside you is that these are the things that are working themselves out as we continue to work together on these, like over the years, the things have been working themselves out, so if we remain attuned to them, is that they will continue to improve, but that is my impression, not remember.
My impression listening to you all talk about your goals is that I actually think that was a very nice way to reflect on the IWG scope and like a shared understanding of it.
But one thing that might be helpful, and it's just a throwaway line, but Jen, back and forth on this. Yeah, who's setting the agenda, and and Sarah has not had a whole lot of time to be actively engaged. But given what we're talking about, setting the agenda and having IWG involvement with the department in setting the agenda, I think that's something that can almost be like a preamble to this, but we just need to express that.
Yeah.
I think we're starting to mesh our experiences together and respect them too. It may take a while to see that. I mean, it was a while before I heard you talk. Oh, she's brilliant.
I will say, too, I
You
think this.
fired it. Sorry.
Steve, just to your point, I think this is also helpful for us as a department. This is part of setting it too, is listening to the goals that helps us understand where we need to go with suggesting material and stuff.
I think that helps me both, it sort of helps you both of the, sort of address both of the.
Yeah.
All right, so the next steps are I'll integrate the changes. I'm going to accept everything that's in the document that you received. So all the track changes are going to be accepted. I'm going to write up the findings or the kind of the goals, and I will circulate to everybody asking you to please keep an eye out and respond to me within 24 hours. And then I'm going to work with Annie and Andrea on, like, I'll make my best guess and kind of putting it all together and then running it by you and making sure that you think I got everything.
When do you try to finalize by?
It has to be finalized by December 1st.
Yeah, so that's like Friday. So you're
So
gonna do
that's
it in the
like
morning? or-
4:45 on
Okay,
Friday.
all right. No, I probably, depending on it, if you send it out Wednesday or Thursday, just first day, I probably the fire station next to me, they may not be able to read it, but if like Friday morning, I can check. I mean, I'll try to check my emails, but yeah.
Yeah, I mean, I could, because by this time.
I trust your work on this.
Okay.
I'll give
And
you a
it's
pre-approval.
It's not a final,
I know.
final
Yeah.
two, so it's not like you're holding to it for another do that. Okay, so I will do that. Thank you. Submit December 1st.
I would say no 4:45 on Fridays.
No.
Because I have to
So one thing, just like in the years past, we've had like Monique used to put a cover letter.
Yeah.
but, I don't.
Yeah,
know
I
if-
think we will discuss.
Okay.
Yeah.
Okay. Yeah, for your well-being in
Mhm.
particular, it'll be before Friday, 4:45. Okay. So, there it is.
15 minutes is plenty of time.
That's when all the systems crash. Okay, next slide, please. Okay, so we're going to move on to public comment. This is public comment in specific to the progress report. So this is the, sixth verse, same as the first. There's nobody in person. So if we're going to focus on those who are online or who are joining by phone. For those participants who are joining online, please, and you'd like to make a comment, please raise your hand and Kaylee will call on you. So let's just do that first, and then I'm going to call on the phone folks. Kaylee?
No hands.
Okay. There's no hands right now, so I'm going to ask also those joining the phone, if you're participating phone and want to comment, please press star and then star again, or pound sign and then pound sign again. Then dial *3 to line up to speak. A system prompt will indicate you've raised your hand. Please wait till the system indicates you've been muted, and you may begin your comments. So if anyone is on the phone, and you want to speak up, please press pound again. Good grief.
You have this memorized.
Those are written on it, yeah. Okay, Kaylee, one more ask. Anybody? We're good? All right, public comment is now closed.
We are moving to discussion item number 5, an update on IWG governance and membership. Pass to Valerie.
Acting chair. So a couple of updates on that. I have my notes with me. So for our board seats, which are that need action, which are seat. Actually, Kayla, could you advance to the slide that has the chart of all the members so that this is a little clearer to see? I think it's an appendix.
That's the very last slide, Kaylee. Yeah.
So the seats that require action at the board. So seat 1, which is a reapplication. Let's see, I just lost it. Sorry. Seat 3, which is vacant. Seat 7, which is a reapplication. 8 and 11, which is reapplication. Those are the board seats that need action.
Wait, 8 and 11?
Oh, yeah, those are boards.
And these are, I'm going over the board ones.
POS.
I'm going over them separately, yeah, because they have different procedures.
Oh, and so the board one was Scott.
I believe so. Yes, so again, so the board seats that need action are seats 1 needs a reapplication. 3 is vacant. 7 needs reapplication. 8 is vacant. 11 needs reapplication. That's the group that we're talking about here. So I just received one final application for 3 that made me go, ooh, so I've asked that person.
You did get applications for 3?
I've gotten a ton of applications
Oh,
for
really?
3 more than anything else. And so it's been a challenge wading through those candidates. I want to be very mindful of that this is a heavy lift, but this is something that folks are cognizant of everything what needs to get done. So I have one more conversation for that. I also just got an application for 8, which is like the first one. I'm very excited about the first one. Yeah, so, but.
I can't believe other people have, it's took this long.
I know. So I'm gonna be reaching out to that person to talk to them. And then primarily I'm waiting for a reapplication for member short. And given the delays on some of these, I've told the clerk that I will submit later this week for at least 1, 3, 7 to get the hearing scheduled for them so that we can move. I respect that they wish to move them forward as a group, but I think we need to move. We can move. Sarah can continue to serve without doing the reapplication in this round. So, and for the mayor seats, which are 5 and 9 and 3, I requested a meeting this week with our contact there to elevate my concerns about moving those seats. So I think it's urgent. I want to have the opportunity to stress that to them. So that's 5, 9, and 12.
Yeah, 12,
Yeah.
Kaylee, I like, yeah, there you go.
Yeah. So those are my updates. I'm hoping when we meet in 2 weeks that I will have a little bit more. I also want to note that if your seat expires in 2024, I'm going to start reaching out to you directly to discuss your plans, whether you're interested in continuing, and whether we need to, or whether we need to start teeing up. They hold applications, so we have other applications on file that maybe were not a great fit for the seats that they've applied for, but could work for other seats. And so I want to start figuring out how to jigsaw those together. So.
And Valerie and our team talk about this on a regular basis, and I just wanted to thank Valerie for just.
Me too much for this.
Well, he could just go in and try to find, to move this forward, so thank you.
I know this has probably been done because I haven't followed what your outreach has been, but for the lived experience positions that have you attempted to get recommendations out of either the Mental Health Association or the County Mental Health Advisory Board?
I think we could get recommendations for some of the other seats. I think we have a wealth of applications for the lived experience seat that is vacant and not as much for the others. And that is
okay. We just haven't been able to screen them yet. Okay.
We've been screening them. The request typically is to advance these as a group. And so it's difficult to try to get everybody aligned to advance at the same time.
Okay.
I don't think we're going to quite hit that, and I've been trying to push it forward regardless. So I appreciate the recommendation. I'm grateful that we have as many very good applicants for 3 as we seem to. I wish I could take them all.
Any other comments from IWG members?
Just one quick question, because we've talked about it before, but in terms of the outreach, in terms of the response, I don't know how direct this has been, but have you, I know that there are people who are concerned about the commitment. Are there specific kind of barriers to participation that come up regularly?
Yeah, I mean, it's not compensated, and not everybody has an employer that would support them in taking 4 hours a month to come here and participate. Depends on your employer whether they view this as civic engagement or as part of your job. And so that it's the middle of the workday, it can be challenging for folks to do that. I will say, I think in terms of recruitment, we need ideas for perhaps like professional licensing bodies or something we can leverage that I think, the majority of responses I've gotten to outreach, because they're coming from our outreach, from our networks, have been like DPH employees, and I can't see the whole body as DPH employees. That's not the point. And so I think we need to leverage some other organizations to increase the trend. So.
And of course, one of the ongoing dilemmas in the CBO community or the nonprofit world is, because I mean, it's real helpful to have people who have experience with the system from the various perspectives, either as providers or as, people who have had to navigate the system. But if you know the system well and you're working for a provider who might be willing to release you to add that information to this body's deliberations, the conflict of interest makes it difficult to decide what you can share. So there is that barrier as well.
Yeah, I hear you. I think it's a, you know, sort of a small pool we're all swimming in together in some way. Yeah.
The others? All right, let's move to public comment then. No one's in person. So we are going to first call on the participants who are joining online. If you're participating online and would like to comment on IWG governance and membership, please raise your hand and Kaylee will call on you and unmute you. And we're going to pause for those who are online.
I'm not seeing any hands.
Kaylee, do you see any hands?
No hands.
Okay. I can get it right this time. Definitely call who's joining by phone. If you're participating by phone and would like to comment, please press pound and then pound again, then dial *3 to line up to speak. A system prompt will indicate you've been unmuted. Please wait until the system indicates you've been unmuted and you may begin your comments. So if you're by phone, press pound and pound again and go through the process. All right, I'm hearing, was there somebody, Kaylee?
No, I said no hands.
No hands, okay. Hearing no callers, public comment is now closed. So we will move on to planning.
We are moving to discussion item number 6, a discussion to co-plan the agenda for our next few IWG meetings. Take it away, Jen.
This is our second meeting that we're doing this kind of more intentional planning and slowing down to pause and talk about what's coming up and what we want to talk about. As we discussed last time, you know, these are potential upcoming topics that are identified by DPH as, and some of these are things that we need to talk about, and some of these are things that we could talk about that DPH has identified. So I'll talk about those. I just wanted to remind everyone, like, our next meeting is 2 weeks from now, so it's a very short period of time to be able to queue anything up. So I know
It's on a Thursday?
Yeah.
Oh.
Yeah. Yeah, we had a new time for this meeting because it was flying with the holiday. So, you know, like, I know that the OCC is of interest. 2 weeks is not enough time for adequate preparation for that. So I would highly recommend that we put them down for January. But so if you look, like, some of the potential topics are required is we need to nominate a chair and a vice chair. So everyone, be thinking, chair, vice chair, look what a great job Andrea did. Like, and we're, you know, the list is not very, you know, we're doing a lot more co-development and co-designing, so it's not going to be sitting on the chair's shoulders to have to do that. So in December, we will be asking for nominations and including self-nominations. We're going to get community engagement updates. So Interethnica is working on the mapping. So using the maps that DPH has designed, they are going to be going into the community in 2024 and getting feedback from both providers and from consumers and services. And they'll be bringing that back. So we'll hear from them. Rise. It's going to have, we have a evaluation presentation. They've been bumped month after month. So would really, I think they would really appreciate coming and doing that. And it is kind of, there was a lot of mention from Rise today. So it's a nice carry on of what we've been talking about. Of course, we always do we're going to start doing those round robin domain updates. Did that work today? What Marlo did, like, she kind of went through each component that had an update. Okay, hold that thought because we're going to continue to test it, see whether it works. All right. So those are the kind of things that we were thinking about. Again, just given 2 weeks, there are a bunch of upcoming topics that are coming up, like staff and wage analysis. We will have to talk about DPH's annual implementation report, ongoing conversation with Interethnica, and the overdose prevention dashboard. and now HSH, right? And OCC. So if you just think about December, I kind of think between those four things, nominations, community engagement, summarize, round robin, that's pretty full.
Especially for 2 weeks.
Especially for 2 weeks. So is it appropriate to kind of keep it to that agenda? Is there something burning that we need to make sure we cover before the?
I'd like to see the summarize.
Me too. I was just looking
Yeah.
at that.
Okay.
It's fine.
Okay.
Does it make sense to do the chair and vice chair nominations before we have it sounds like we're gonna get some new members. But does it make sense to do it now?
Well, they expire in January, so Sarah.
Okay.
Okay, and then we have the other ones that HSH and the OCC will add to that upcoming topics under consideration. Are there other things that are on your minds that we need to make sure that we bring in future meetings?
We can always have an agenda item to brainstorm. What we want to do.
We'll do it every month?
Yeah.
Yeah, I mean, well, we discussed the huge one today that could be an entirety of February, right?
Right, yeah. A huge one being between OCC.
The HSH, the
Okay.
HSH, and, DPH. Housing.
Yeah, okay.
That will take a couple.
All right, anything else? All in once. Steve Fields, anything on your mind?
So many, no, nothing. I'm ready to move on.
Wrap it up? Okay. All right, then let's move to public comment. Okay, nobody's here in person. Unless you're joining online, if you're participating online and would like to comment, please raise your hand and Katie will call on and unmute you. We're going to pause for you. Raise your hand if you would like to comment on our planning agenda and what we're going to be talking about in the future.
We do have 2 hands and Sarah will be the first. And Sarah, you are unmuted.
Hi, Sarah. I can't hear you. Sarah, would you check here to make sure you're unmuted? Kaylee, do you see her as unmuted?
Yeah, I unmuted her. I do have another number too that has the hand raised.
Okay.
It's a call-in user. I wonder if that's her.
Oh, maybe so. Okay, let's do it.
Let me try to unmute that.
Are they unmuted?
Hello.
Yes, hi, we hear you.
Oh, okay. I just called to put a reminder out there that I applied for seat 5, and I also am available for seat 8. I haven't heard anything from anybody.
Thank you. Okay, thank you. Is there another caller? Haley?
I don't think so. I think the caller was Sarah.
Okay, all right. Thank you. All right, the next one. Okay, final verse, same as the first. Go to the next slide. All right, final public comment on any other matter within the jurisdiction of this committee that is not on the agenda. Nobody's here in person? Raise your hand if you are online and would like to provide comment. Kaylee will unmute you. Kaylee, do you see anyone online?
No one with the hand raised.
Okay, now I'm folding in those joining by phone. If you're participating by phone and would like to comment, please press pound and then pound again. Then dial *3 to line up to speak. A system prompt will indicate you have raised your hand. Please wait until the system indicates you are unmuted and then you begin your comments. All Kaylee, anybody that you see anywhere in our system has a hand raised or wants to provide comment?
No, I do not see any hands.
Thank you. Public comment is now closed. So a little bit of housekeeping, requests from other city bodies or groups. Oh, I meant to ask, did anybody attend our city art hall?
That's what I.
Ah, okay.
No, they did not because of APEC.
It
It's canceled. Yeah, or it was canceled and it was moved. So I am here again. I know they asked last month, so this is a reminder, I'm pulling up the email. So the Our City, Our Home Committee has invited the Homelessness Oversight Commission and the IWG to join an upcoming meeting to have a discussion with them about key challenges within the system of care and where there might be opportunities for collaboration. Very kindly, Member Hammer and Member Short both volunteered. This was canceled due to APEC. The location was within the closed area, and switched to the December 8th OCO meeting. Member Hammer can't join, and I know.
Oh, I can.
You can now.
Yeah,
Oh,
I'm not going to that.
Okay.
Yeah.
So could I invite a backup, because I don't know that, Member Short has had a number of personal things going on. I want to confirm, but I ideally would like to send 2 people if we can. So this is December 8th, from 2 to 4:30 at City Hall.
Yeah.
Is anybody else, would you be interested in going? Okay, awesome, great. That's Member Patterson, Kaylee, Member Patterson and Member Hammer are both going to be our peoples.
Great, so I will reach out to you guys that were confirm and I'll try to confirm with Sarah, but Member Patterson, I may put forward since they need to know quickly. And I know she's had a lot going on, so that is great. I think that'll be a great discussion for you guys to have, so thank you. Okay.
All right, there are no discussion groups in the next 2 weeks, except for Andrea and you will be helping me with the report. Meeting minute procedures, they're always posted along with other resources. I really encourage all of you, is like we try to keep the reports and resources updated. So we'll be putting like the dashboard of the different SCRT reports there. You know, but there are other things like the treatment bed links, all of those things are hyperlinked so you can find it. And of course, public input. We monitor the mental health SF IWG email. If there's something that comes up, please do write us.
Are there emails?
Basically never. They come to me.
All right, I'm just curious.
I think it's been 1 or 2 years. Next
But it's
slide.
monitored.
Yeah, right, yeah, we're looking. Next slide. And this is just a reminder, there's a lot of things that are going on in the city. The Board of Supervisors Homeless Behavioral Health Committee meets on the 2nd, 4th Friday. Our City, Our Home Oversight Committee, we have 2 members who will be attending that. Thank you, thank you, thank you. Behavioral Health Commission has 4 different subcommittees and of course the Health Commission. So there's lots of opportunities to hear more about those and to also notify us if there's something you hear that you want to bring to this.
Have we had a presentation from Sue?
Presentation from BHC, Valerie, we haven't.
I don't think so, but listening to you guys talk, I think client council, BHC coming sometime to a meeting or some kind of joint conversation would be great. Yeah.
One quick mention, I had a meeting yesterday with Supervisor Walton, who's one of the members of the Homelessness Behavioral Health Committee. He seemed to indicate that select committee would be wrapping up this year and would not be working again next year. So he didn't give details on it, but you know, they've and then the remainder of this year, Fridays are at risk because of the holidays and stuff. So do check to make sure there's a meeting before you go to those.
Right, what did you say? It's ending. Yeah, she confirmed it's ending. Thank you, Steve.
Okay, thank you everyone for this meeting. Our next IWG meeting is the rescheduled December meeting, which will happen in 2 weeks on Thursday, December 14th, starting at 9 a.m. at our usual location here at 1380 Howard Street. Can I have a motion to adjourn, please?
My motion.
Thank you.
Patterson motions,
Anyone second?
a second.
Thank
Hammer
you.
seconded third.
Good.
Andy said third.
We will see you in 2 weeks.
Thank you.
Hey, can we get a group picture right about this?
Is this for your holiday card?
That's funny.
December 14th.
December.
Yeah, it's your third day, right?
So that's for the December.
Yes.
Okay. We have a month and a half.
Quick turnaround, then long layoff.
I'll get you a picture.